वो ये कंप्यूटर है.
वो स्ट्रीम हो रहा है. So good morning to all of you. Welcome back after the breakfast. We have a slight change in the schedule because Dr. Surya became suddenly unwell in the morning, so he had to rush back. What I'll be doing, I'll be taking this first presentation, and if time permits later, we will add on to it, and maybe at that time you all can have some questions and discussion ready for us to discuss on this. What I will be talking about in the next 20 odd minutes is what we have done specifically here in the trauma center, and I'll just come up. How we can use innovative technology to actually help our patients and improve the quality of service delivery, especially in public funded hospitals. So if I talk about what is there, this was a lead article in one of the major papers, you can see it, and this is the issue in government hospitals in India. What is happening is, if you look at the bed ratio, currently private hospitals outnumber government hospitals by more than 3:1 in the number of beds. Even the poorest of the poor patient would want to go to a private hospital first rather to a government hospital because of the service delivery which is lacking in the government hospital. It's not that they lack anything else. Infrastructure is there, doctors are there which are the best of the breed, nurses are there, but it is the service delivery which lacks, and that is why everyone would rather avoid a government hospital than actually come there. Although if you look at the actual system in place, it's a beautiful system. It's not been worked upon properly, and I was talking to principal secretary of Arunachal yesterday, and because he's into political, he's got an interest in political affairs, he reads Russia, and he was telling me that Russia, when it was a socialist country, the infant mortality was less than 50% of what it has become now under a capitalist rule. Because at that time, 10 years back, this was socialist states, every child had to go to a government's, everything was paid for, the hospitals were there, everything was working, with whatever deficiencies, and they had a beautiful system in place. Now that system has been taken away, everybody has to go to a private system, and although Russia is much more richer than it was previously, people in the villages, and they simply lack, and they would rather prefer doing everything at home than go to a hospital. So infant mortality is actually doubled in Russia, which is an eye-opener. I didn't know that. So you cannot just remove the government system and say the private is the panacea for everything. That is the bottom line. We need to build on whatever we have, make it better, rather than continuously criticizing it and not doing anything about it. So the primary objective when we built this trauma center, and I specifically held this workshop in trauma center so that you can have a look at this. This is also a government hospital like any other government hospital in India. There is no difference, except that we are very proud of it. And the reason was, when we started, Dr. Mishra was the chief of center when this was started in 2007. And our basic objective, we had a meeting and he said the basic objective, we should try and do something different, because there are 7 centers in AIIMS. They are in the same campus, okay, and it looks like a normal government hospital. A lot of dirt, a lot of people, population, all kinds of problem which plague every other hospital in India. So we say we should try and improve the transparency and accountability and use of information technology. That is the key word, which we can, whatever we do, we should do it with the mission that it can be scaled to a national level. So this was the primary objective. The other priority obviously was to improve the patient satisfaction, and 2 major areas which every patient is faced with. One is the emergency department, and other is the clinics or the OPDs. And third was we could, if we could improve the online services like the website and other web educated patients actually can interact with. And in this regard, AIIMS is unique because right from the Prime Minister to the poorest come to the same hospital. So you have to cater to different kind of what I would say is aspirations and expectations. So I'll be talking about these four, but there are many more because of paucity of time, but I'll just discuss it during this presentation itself. These are the things we started here at Trauma Center. Now obviously we have, I would say, 20 odd initiatives in place which are unique. And these are the four things I'll just briefly talk about. If you talk about a call center as a concept is alien for hospitals. So we have call centers for telecom companies where you phone up, you get your number changed, you do a lot of other stuff, put in a complaint. Our mission for having a call center was very profound. We wanted to have a system in place which was not dependent on the individual. You have to look at the philosophy. We are not talking about IT comes in, but it is the systemic process which we implemented. What is happening is whenever a patient comes in contact with a government employee in any service delivery area, it could be hospital, it could be any other delivery area, there is a chance of corruption coming into the system, because that person might say, okay, I'll have you cut the queue, I will get your X-ray done, I will get your services done, you pay me a little more and I will have it done. So the human contact is something we want to avoid. So if you remove the human contact and say, okay, everything you will be doing over the phone, over the net, then that itself significantly will cut down the corruption, number one. Number two, when we, for thinking of call center, people said, why don't you have the call center in AIIMS itself? You have 10 people which can be under your direct supervision sitting there, and they can do everything. You can have 10 data, 20 data entry operators doing the call center function. So we said, no, we don't want that, simply because as soon as you recruit a person into a government job, he becomes a babu. Okay, he will not be sitting there. He most of the time he'll be on tea, going to the washroom, talking something else, and he will only break the system. He or she will only break the system because they know the system inside out. They will only interact with the people who are coming, and they will tell them to come here again. The corruption cycle will start. So we said, and add to that, you will be using space, electricity, parking, everything you add on each person. Nobody makes a calculation on how much are the ancillary facilities the hospital or any other area has to provide for them. Right from toilet to parking, these are major issues in AIIMS, and they continue to be issues everywhere else. Yet we continue recruiting people without thinking of what are the other things, right from canteen to all these facilities which we will be able to cater or not. So we said we don't want any of this. We want it all outsourced. So we should be separate, in fact geographically separate if possible. So we tendered for this, and we had a company come in which was located in Uttar Pradesh and Noida in fact as L1, and currently they do a lot of activities. So I right from data mining to informatics to follow up, and I'll talk about a little because I'm just looking at the watch. As soon as a patient comes into this hospital, I'm talking about trauma center right now, we have implemented an AIIMS also recently, around a 1 month back. The relative will get a phone call within 30 minutes. That is our SOP, because the EMR is linked to the call center in real time. So when a patient registers, automatically the data is seen at the call center. So they are supposed to phone up and give a welcome message, saying that welcome to, in Hindi, saying welcome to trauma center. We hope you have pleasant experience. In case you have any problem, just give us a call. This itself empowers the common man, because right now he doesn't have anywhere to vent his anger or his frustration. So you suddenly have a person welcoming him and telling them this is the number you can actually put in your grievances. and we have such a positive feedback on this welcome message itself. But our vested interest was much more. We wanted actually to verify the phone number, because unless we have a verified phone number, the call center cannot function. So we wanted the phone verification instantly, because the people on the ground can get the right number back into the system in case it's from faulty. Because once a patient leaves your emergency department, you have nowhere to track him if the number is faulty. So that is why we had the system in place, and we currently have more than 90% authenticated numbers on our database. So every single patient coming in gets authenticated, unless of course he's unknown or there's a problem, we can't get his number. After we get the number, then it opens a gold mine for us, because then we schedule the patient's appointment. We keep a feedback on him. We track him, how many patients we are actually treating in this hospital and sending across, what are the kind of diagnoses we are. Every data is available to us, which the call center can analyze as per our wishes. So you have a whole team ready, which are computer savvy, to do all informatics work at your beck and call, which is a huge thing. You know, we as doctors are also acting as researchers and doing our data analysis as well. So it is eating into a patient time. So I think what we should be doing is giving the vision that that is the data we want, and somebody else should be doing properly, authenticating the data and getting it. So this is one thing they're doing in terms of research. The second thing in research they're doing is follow-up. Traditionally, follow-up is lacking in all government hospitals. So we hardly have any follow-up data. They guarantee follow-up, because they will call up the patient, they will fix up the appointment. In case the patient doesn't come on the desk, they again phone up, why have you to come? So we have a now follow-up more than 90% for all patients, because the numbers are there with us. And because they are booking appointment, what our system or policy of working is, we believe that patient will be so poor that he will not be ready to even spend 1 rupee on the phone call. So it's all proactive. The call center has to phone up, because that's funded by AIIMS, by the government. So every patient, the call center phones, not we wait, we don't wait for a call. So they will phone up, they will book the appointment on behalf of the patient, act as a human middleware. Because the second assumption is that all patients are illiterate. So if you work on these two assumptions, then you're serving 100% of the country. If you say no, some may be literate, they might do something, we are not bothered about that, because they can obviously find something else to do. The two assumptions, that patient is very poor and illiterate, and you have to get him on board by hook or by crook. So they phone up, book appointments, make sure he comes on the designated day. The appointment list is sent to the doctors with the diagnosis, so they can again check, and they update the diagnosis in the system, so that we get a research data which is getting cleaned over time. It doesn't happen over days. So once appointment, maybe it's not properly, diagnosis has not been made, but over 1 year, 2 years, the data automatically gets updated and cleaned. So it's a huge mine of data which is cleaner than possibly you can ever get. The second thing, if you want to improve the functioning of a system, you have to document and show what you're doing. So if I talk about ourselves as a patient, you would only want to go to a doctor. If we are all educated here, we would only want to go to a doctor who, according to you, is one of the best in that field. And how do you decide a doctor is best in his field? By seeing his or her complication rate, what is the mortality and mortality, how many patients you have done. Now there is no data on this. No doctor in the world gives this data. Okay? No hospital gives this data. So how do you do it? You just go by experience or by other hearsay of other patients. But as an educator, you would want that data, and I think it's a right of every patient to know that even if the doctor data is not there, at least the departmental data should be there. That in this hospital, in this department, for this disease, this is the complication rate or the absolute mortality rate. Let's put a very simple figure, absolute figure to it. A 30-day mortality rate, what is there? Now, if you have the data, you can make an informed judgment. Okay, this department is relatively better. But I can tell you, not even Harvard, not even Johns Hopkins, no hospital in the world does that. And we said, okay, there is nothing to hide. We will put it up. And we put all our data for the last 5 years. We've been putting audit data on our department. It's public website. And you can go through it, jpnatc.org. And for every department, for all diseases, we are showing what is the complication rate, what is the mortality rate, how many patients are dying, and you can see over the trend over the years. So, and we have thrown this as an open challenge that other hospitals should also show the data. Yet over 5 years, we haven't received even one, either a complaint that your mortality is high or low, or somebody else has tried to compete with us and put their data up on this. So this is why people don't want to be transparent, because once you put it up, this can be shown in the court of law that they have this data on the website showing that this is the mortality rate. Yet we had, and this is only because Dr. Mishra agreed or supported us in allowing us to put this data, all the audit data on the website, and we have been doing it for last 5 years now. The second thing which came on the screen was when you talk to a patient, one of the major pain points for a patient or the relatives in the emergency department is that they keep waiting. They either keep waiting for the X-ray or waiting for the doctor or waiting for CT, whatever. So the waiting is the most painful. We all know it. When we stand in line, it is the most painful thing. So when we talk to the doctors why the patient is waiting for so long, 2 hours, 3 hours, the emergency physician says that we are immediately seeing the patient and writing the test. So our work is over. You talk to the radiologist, he says our CT scanner is the top end 128 slice. We get the whole body CT in 30 seconds. So we are not at fault. As patient comes, we immediately do. So everybody says that they're doing a perfect job, yet the patient is waiting 2 to 3 hours in the emergency. Why? Because the patient perspective is completely different from the doctor's. From the patient, the time starts from the time he's been ordered a CT to the time it is interpreted by the treating specialty. That is for him the CT time. Because unless the treating specialty, it could be a neurosurgeon, could be a general, sees the CT, decides the management, for him the CT is still not been done. So we said, why don't we put this statistics up? Because we had a patient display system, I'll talk about it. And this is the patient display system which we talked about. Is we created an electronic medical record. MLC we all know, out here we have a medical legal case, but we just computerized it. The reason was the data capture. And we were getting a lot of data points into the system, and we had a dedicated team of nurses known as nursing informatics, which are there 24/7 in the emergency, which are putting in data points when the patient was ordered CT, when was CT was done, when was it interpreted. So all this is coming in at the back end. We are getting time points and we are showing it in real time on the website. In real time on the website, and this is all informatics. Analyzing it, putting in algorithms, showing how much time for the last 5 patients and over the last 1 month, what is the trend for the waiting time. And it is, we have put arbitrary cutoff at 3 hours, otherwise it can exceed 5 hours also. This is here also, but we put an arbitrary cutoff at 3 hours so that the data points and mostly averaging around 2 to 3 hours. That's what the patient stays here in trauma center. So when we put it up, there was a lot of hue and cry from internally from our own doctors, and people complained to the director and the current chief, saying that the department, radiology especially, is being portrayed in poor light, because time for CT means that they are at fault. We explained the perspective, and finally, and thankfully again Dr. Mishra stood by us saying that yes, it's a good thing, because the only way to change anything is to first document. That is where documentation and informatics come in. And second is to show it as a mirror to everyone. So to change a system, it is not necessary to actually punish or scold or do anything. You show that this is happening and people will change slowly. And this is what has happened. There's been a definite trend towards decrease in waiting times overall, because people know that yes, it's a teamwork. Everybody makes a difference in the emergency department. So the patient display system, I think, is a very unique thing. And why? It's because again, what we wanted was like the airline display system. We have a patient display system where every single patient's data is coming on a big display TV, and which shows Hansraj, which shows the diagnosis of the patient, the criticality, what he or she is waiting for, and what is the final, not the outcome, but final referral, what is the plan. So again, there were two major controversies on this when we started the system. One was confidentiality of patient data, number one, because we are showing it on the screen. You can see on the screen, it's a big screen out there. You can, when you go around trauma center, all those who have not visited, you can see there's a big 50-inch LCD which shows every patient's name, age, everything, and what are they waiting for. And these green things mean, red thing means they have not been done, green means it has been done. So patient confidentiality was the first major bottleneck, and the second was how are you going to be using this data. Okay, so we said, and this is not a unique thing in India itself. In case of any emergency or disaster scenario, confidentiality takes a backseat. That's the legal point across the world, because if you had a patient who had an accident, no hospital would ever tell you that patient's in their hospital or not, because they would say, no, we cannot tell you if this named patient is here or not. So in any emergency, in any disaster scenario, you can freely show the patient details. Okay, so this is one thing which came to a help, and it is done in America also for that matter. So we show the patient's details. The second thing which people told us, look, you are assuming that every patient is illiterate, then why, if you show everything English, how is it going to make a difference? Now the important thing to understand is that this display system is not only for the patients who are educated, but it is more for the doctors and nurses working in the emergency department, because they have a dashboard to see how many patients they are, what are the patients waiting for, and if anybody asks them what is going to be, they can look at the dashboard and tell them, rather than running around and saying that I don't have time, because everybody is hard pressed for time. And our motive was again to get the data which is coming in from the back end, analyze it, do analytics on it, see which departments are coming late, what are the referral times for seeing patients, why we are not doing such a good job in a lot of things, and then improve it, because documentation is the key. So we use this. I haven't even talked about what EMR, what PACS, what HIS, everything, because they are there. Let me tell you very frankly, any system will do. It could be open source, it could be closed, anything. Any software, because there are umpteen software available in the market. It is how you implement it, because even we all go for the maximum number of bells and whistles in any software, but if we can implement the base version very nicely, 90% of your work is done. You look at your mobile phones, smartphones, there might be thousands of features in it, yet you might be using hardly 10 features. So people will always sell you a maximum, kind of thing which you will never use in your life. You should be looking after what is important for you. And if you can get those 5-6 features working nicely for you the day is made. So similarly, we went in for open source. We had a very clear mandate that we wanted things to be on the system, and which should be user friendly, which the nurses could make templates, implement it, and we were very, very successful in this regard. So right now our electronic medical records are 100% here in trauma center, and I would say around 60 to 70% in the whole of AIIMS. Because you're not capturing every point data. Doctors' notes, medications are still on the written in the on the paper on the rounds. What we do as a unique thing is, we scan the whole sheet immediately at the time of discharge or death of the patient and attach it back to the EMR as a PDF file with a link. So you can, as a researcher, I have the whole file available for review at any point in time in a digital format. And whatever data is there anyway, and as the admission note, emergency note, the operation note are there in actual typewritten things, plus the lab data coming in, plus the PACS data coming in. So it becomes a very robust, low-cost platform for us to work on. And we have been able to, actually, if you look at the total cost, I would say it has not, it is peanuts We have not felt the pain of ever spending money here, and the software itself was free, so there was not a major issue for us. The biggest I would attribute the success is to our team, which is the nursing informatics. They are the clinical nurses who have been trained to act as an interface between the doctors, the healthcare workers, and the IT team. So they are the ones who ensure the success. They make whatever targets we said that we have to get this live. They are the ones who do everything. So without that team, you cannot achieve anything. What happens traditionally in a system is you pay money to the vendor and you expect the vendor to do everything, which will never happen. Because the vendor will set up the software, he cannot change the attitude or do a change management of the place. That you have to do yourself. And people feel just by paying money you can do change management. It's not possible. So you have to have your own team which does. And so our own team does 90% of the work. The vendor responsibility is just to install, implement the install the software and do the changes in the software or customization as we want. That's all. And the third thing I think is, unless people know that change is happening, they will not be very amenable to change. So that is why we push all these huge LCDs, LEDs, put all these dashboards up so people can know that this data is actually coming into the system. They're all seeing it. They are being part of the change, and that's why they're more proactive about it. So as I told you, I would want you all to, whoever never seen this trauma center, to go around it during lunchtime, and we are very proud of it. And we have replicated the same software and everything, the same model here in AIIMS, which are around 2,500 plus beds, and in less than 18 months. So again, thanks to nursing informatics team which we developed there. We have a MOU with all the 6 AIIMS directors for implementing it there, and currently I think AIIMS Bhopal and AIIMS one more place, they have actually implemented the same software and it's running very nicely. Although the hospitals have not come up totally right now, but the OPD and whatever inpatients they're running, they're using this software. And we got a lot of awards during our journey out here, and this is just to show a brief presentation on what we have done here in Trauma Center. Obviously, this is a very small part of what we have actually attained in terms of informatics, but to give you a bird's eye view. Thank you so much. So any questions? I think I will take the questions later on in the afternoon. So we'll get the presentations over. If that is okay with you, Shyam. I think so. Okay.
What is the flux of or amount of patients handled by your system?
By system.
Yes.
So we are getting
flux.
I understood. In Trauma Center, we are getting around 35,000 patients a year. So all of them are coming through the system, of which we are handling around, I would say, 10,000 admissions. So all those admitted patients again through the system. And the same system is there at AIIMS. So in AIIMS, the OPD part we have yet not computerized. Registration is there. So we are registering around 15 lakh patients a year on the system. So all their lab investigations, everything are on the system. And for inpatients, we are doing, we have 2,500 beds. So every day in the emergency itself, we are getting around 600 patients. So there every data is on the system. Plus, I don't know how many inpatients, but we are operating around 1 lakh surgeries a year. So obviously all that data is on the system.
And you store all that into main servers or on cloud?
No, everything on premise. On premise. We have our own SAN and everything. Yes, on premise. Everything is on premise. And we have, we have not put all our eggs in one basket. So we have multiple vendors. So that is also one critical thing. You should not say only one thing will, because people feel that interoperability will be a problem, this will be a problem, that. So we say don't mix. Like PACS can be a completely standalone program. Later on you can think about having interoperability. HIS, you only need basic demographic interoperability. You don't need to send 100% information across the two programs. So we have HIS by NIC, National Informatics, and we kept them at that only. We said we don't want anything more. So HIS and the appointment system they do, and the stores. So we don't want too much clinical data coming into the from them. almost nil. Lab data is there, but lab data is coming from anywhere from an intermediate program to them. So that intermediate LIS sends it to our open source Vista also. And all the patient data is on the Vista. So we have a separate LIS with a private company, which is, we have interfaced more than 100 equipment all over the, and in fact we have interfaced ventilators also. So the ventilator data, monitor data is now automatically coming into a system. So if a ventilator is connected to a patient, the automatically based on the bed number, that ventilator data and the monitor data, pulse is going to be coming to. So all our lab machines, almost all lab machines, major machines all over AIIMS are interfaced already. Some of them bidirectionally, but 100% unidirectionally. And so it's a data goldmine in terms. We haven't still decided what we're going to do, but the first step is get the data in. So our vision is that every single piece of data should be coming into the system, because all this data, the value may be realized decades later. At a specific time point for a specific patient, how to analyze, and this is where informatics will be the key, that you have big data analysis coming in. So when you have so many points, millions and millions of points for each patient coming into the system, then you can decide what is to be done with that. So right now we are working at the basic level, getting the data into the system.
So one small question. So this huge amount of data is available. Is there any system to get the data for research purpose if somebody wants working on
Yes.
some scans, ultrasounds,
So
or MRIs?
that is, the system remains the same, like be it paper, be it MR, you have to have ethics permission. If you have ethics committee permission, then there is no problem in getting the data. So any retrospective study or any kind of study you plan, you have to first make a study out of it, give it to the ethics committee. Ethics committee decide, okay, if you are from a different department, what is your role in getting the data? Have you included somebody from that department? What is it? Is it right to give you the data? They take all the ethics opinion. Once they say it is fine, they give a letter, then we say fine, we'll help you with that.
So even for somebody from outside AIIMS?
From outside AIIMS, you might not be, because ethics committee might not permit you. That system remains the same as it is previously. So you cannot get just data by requesting. You have to put into the ethics committee of AIIMS.
Not even the clinical data?
Nothing.
Not the details?
Nothing. So now I next invite from GCRI, Dr. Anand. So he'll be talking about his experience.
Okay, good morning. My topic is perspective of M-Health in delivering cancer care. So first, I will start with introduction of my institute, then objectives of including M-Health in cancer care, then benefits of its inclusion and probable challenges. First of all, GCRI is a nodal institute, and right now it has been upgraded up to the State Cancer Institute in Gujarat. It caters nearly 3 states, that is Gujarat, Rajasthan and Maharashtra and Madhya Pradesh, 4 states. Basically it's a 650 bedded hospital, and we are going to upgrade by 2016 to 1200 bedded purely cancer care hospital. So it will be one of the largest in India. Okay, now why we should include M-Health and why it is ideal for India? Because in India we are having a large geographical area. There is urban-rural division. There are hilly regions, islands, deserts, coastal areas and tribal areas where a tertiary care hospital is not possible. And again, the doctor population ratio is 1 to 1700 people, and that is overall. If we talk only about the rural areas, then it would be 1 for every 4,000 people. Okay, so by including M-Health, our objectives will be easy accessibility for screening and early detection of cancer at remote or rural places with the help of mHealth. Second is to provide surgical follow-up. Third is to establish the mHealth consultancy. We are having two units. Our nodal center is at GCRI Ahmedabad and other center is at Sidhpur, that is nearly 150 km away. So we can have a consultancy between both the centers. Patient can be the fourth objective is that the patient can be seen by consultant in different wards of the hospital by just sitting at one particular position. And the last is to provide palliative care. The whole the concept of palliative care can be fulfilled by using this mHealth. Okay, now what benefits the patient will have? The first thing is reduction in the out-of-pocket expenditure. I would like to highlight that because of out-of-pocket expenditure, every year nearly 1 to 2 more % of people are coming in the below poverty line. And another reason for that is nearly 80% of our GDP goes in the public health setup, but 80% of the population goes for the private healthcare. So there is an imbalance between public and private setup. Because of that, there is huge out-of-pocket expenditure, and that can be reduced by this mHealth. We can prevent the loss of daily wages, because if a cancer patient comes, he will accompany 2 or 3 relatives. So everybody come to the tertiary center. So we can just prevent loss of daily wages by this. Easy accessibility, because we can bring consultant level care at the doorsteps of the patient. We can have e-rounds between different hospitals, between PHC and the nodal center, between district hospital and nodal center. We can have follow-up services at home for surgical follow-up as well as palliative follow-up. We can have this concept of mHealth. So now benefits to healthcare professional. First is improved diagnosis and better treatment management. We can manage treatment better, because many patients get defaulted or many patients don't come for the follow-up. So by this mHealth concept, we can reach those patients and we can have better management. Again, we can have training. We can continue the medical education and training with this mHealth. We can timely follow-up of the discharged patient. We can have access to computerized comprehensive data of patient, both offline as well as real-time data. And again, the travel time can be saved. The institute can be benefited as we can the one consultant can take care of many centers. Again, the travel cost will be decreased. Better referral system. In India, again, the another problem is that we are not having a proper referral system. All the patients do not require tertiary level care, but again, they all opted to come to the tertiary level. So we can have a proper referral system, that if you are if you require some kind of secondary level of care, then you go to district hospital or to the upgraded CHC, like first referral unit or like that. And only the tertiary level patient or those patients who require those kind of comprehensive care should go to the tertiary level hospital. And again, better management of patient. Okay, now before implementing or before talking much about mHealth, we can also look about some possible challenges. First is the general reluctance among healthcare professionals to trust technology. Second is we are having shortage of IT talent. Again, when we are putting all these mHealth concept in the primary level health worker, like mHealth worker, then we should think about that. Technological blackout. At some times we just become handicapped. Data confidentiality, again, that is an issue, because the patient, each and every patient would think that my video or my photographs will be shared to the other centers. Virus, low internet speed, even in many villages there will be unstable electric supplies. Then patient's fear and unfamiliarity. Again, the patient would feel that I just need to talk to the consultant directly. There should be no mediators between. Low literacy level, quality aspect, government support. Without government support, we cannot work this concept. And again, certain perspective of medical practitioner. If we think that each and every PHC or CHC consultant would directly refer us for mHealth, then again that is not possible, because the PHC medical officer would be having different perspective about this technology. Okay, so these were the basic challenges which I have outlined. You can also share much more challenges, and we can discuss this in the moderation round or in the afternoon. Okay, thanks. Any questions?
Thank you for the informative talk, Dr. Anand. I request Professor Indira Ghosh, JNU, to give a memento as a token of gratitude and respect to Dr. Anand. Thank you, ma'am. Our next speaker is Professor Saptam Sarbadhikari, Project Director at the Center for Health Informatics of the National Health Portal. We welcome you, sir. Please.
Good morning, everyone. It's really nice to be here, and it seems to be a very interesting whole-day workshop. Of course, I'd be having to leave immediately after my talk, but I'm sure that you'd be having a lot of interactions. If you look at the schedule that has been circulated, that's there in your bag, and what is written here is slightly different, because I thought I'd be broadening it. It's not just the legal things, but because now there's a buzzword is Digital India. So what's the role of e-health in Digital India? I thought I'll talk about that with particular reference to the National Health Portal as well. So I'll be talking about the other national initiatives as far as e-health is concerned, which are a part of Digital India or otherwise. Because Digital India as such is actually being spearheaded by the Ministry of Communication and Information Technology. And the Ministry of Health and Family Welfare is also taking a lot of initiatives which are very much aligned with the digital or e-health things. This is actually our portal. If you look at it, its URL is simple, nhp.gov.in. Those of you who are on the smartphone can actually check it right now. It's also mobile friendly. So currently we are offering it in 6 languages. Other than English, Hindi, there are 4 regional languages: Tamil, Bengali, Gujarati, and Punjabi. But we are also going to have ultimately in all the 22 languages, scheduled languages of India. We are very much present on the social media, that is the online social media, Twitter and Facebook. Every day we give 2 messages, one in the morning, one in the evening, in all the 6 languages, which are also tweeted and posted through the Facebook page. So this is the Hindi homepage, the Bangla homepage, the Tamil homepage, Gujarati homepage, Punjabi homepage. We have got a lot of interactive features within the portal. And this is precisely where I think, if you look at the topic of the workshop, health informatics for the use in hospitals, this is where actually, hospitals, patients, doctors in general can have a lot of useful interactions. So we have a general forum for discussion. We have also a professional forum for discussion among the professional. We have a help desk for the implementation of EHR standards. I think during the breakfast, someone was asking me about the EHR standards. So essentially, the Ministry of Health and Family Welfare had notified in August 2013 guidelines for the EHR standards, which is now being revised. So the next edition is likely to be out in a month or 2. So this would be 2016. So we have a forum there in the EHR standards help desk. We have a forum for discussions on implementation of electronic health records. We also have the feedback from the National Health Portal, and as I said, from Facebook and Twitter as well. This is the EHR standards help desk, and here if you look at it, it also gives the links to the free online courses on SNOMED City, as well as the workshops that are being held throughout the country by the SNOMED City NRC, which is currently being hosted at the CDAC in Pune. So we also have mobile app, which is for the hospital directory and the blood banks. So this actually we are going to upgrade very soon, and I think on we had actually launched it formally last year on 14 June. That was the World Blood Donor Day, and since then it has improved a lot. If you look at the ORS, that's the online registration system which the NIC has developed, they give the real the blood availability status from the blood banks, some of the blood banks in India. In fact, we are also doing that in collaboration with the NBTC, that is the National Blood Transfusion Council, who's in charge of all the blood banks. And we'd be having the reflection of, to start with, the daily availability of stocks for different types of blood groups and subtypes. We also started another service, that is the voice web. It's a toll-free number, 1800-180-1104. So where there's no internet, in fact, India, however we may like to see everyone on the net, but it's less than 30%. As of today, less than 30% of India has got access to the internet. With mobile, of course, especially the smartphones, that's changing because mobile penetration is very huge. So keeping that in mind, where there is no internet, but people can use the voice. So right now we have an interactive voice response system that's an automated one. Of course, at a later stage, we are also going to have the call center based. So these are some of the things about the portal, and then you are free to interact on that. Now I'll come back to the more important issue, that is what are the national initiatives as far as e-health that is being taken up by the Ministry of Health and Family Welfare. As of now, actually the hospitals, or in fact all the healthcare facilities means anything. It could be a super specialty 1,000-bed hospital, or it could be a 100-bed hospital, or a 30-bed hospital, or even a single patient clinic, single doctor clinic. So for that, we actually so far didn't have any unique number. So now this is being given, the national identification number. This number is unique and permanent. So even if the facility is no more, the number will not be given to anyone else. The number will remain. So it's a unique and permanent number that is being given to all the healthcare facilities, starting with the government facilities. Already in Goa, all the government facilities have been given the NIN. They have been verified as well. And then other states, hopefully by March, we hope to have all the government facilities allotted this unique number, which could act as probably as a primary key for getting the data from the different types of hospitals. As you are all aware, India is now a country member of SNOMED-CT, or rather IHT-SDO. So SNOMED-CT is essentially, it's a standard it's a vocabulary standard. So if you need to interchange clinical data, then this could be very useful in ways more than one. As far as the regulatory aspects are concerned, the National E-Health Authority is in the process of being set up. So for the National E-Health Authority, actually a concept note was prepared, and that was in the public domain, and I believe some of you also gave comments on that. We are now actually compiling the comments and revising. Based on that, we'll have a revised concept note. Then we are also going to have a national level stakeholder consultation. So it will probably be a one-day workshop, either this month or the next, following which this National Health Authority concept note will be finalized, and probably it will then go to the cabinet, and then it is likely to become a reality through an act of parliament, which of course could take some time. But then if the act of parliament way takes a longer time, then there may be some executive order or ordinance. Those things are, of course, right now we can't say about it. I'll just spend some time on the standards. I mean, why do we really need a standards? Because we are having multiple systems even within the same hospital or even in the same department. But we need to actually exchange the data meaningfully. That's most important. I mean, just exchanging your data also doesn't serve the purpose. So we should know what are we exchanging and what does it really mean. If you look at this health concept triangle from Scott McIsaac, there are different types of standards for interoperability as far as health is concerned. And different standards actually serve different purposes. I mean, the good thing about standards is that there are so many, but then why are there so many? Because we actually need to have different type of standards for defining and understanding the different types of information and knowledge that is encoded in the electronic health records. So just keep in mind, just because we are using one standard, it doesn't mean we don't need another standard, or if there are more standards, I mean, it's not that they're all contradictory. But of course, we need to know which standard to use and when and where. So if you look at it, the broad categories of a vocabulary, content exchange, transport, and privacy, security, and confidentiality. In the vocabulary, you know ICD, all are aware of ICD, and ICD-11 is just around the corner. SNOMED City, LOINC, and there are various others. So this is the SNOMED City website. I would urge all of you to actually visit this, ihtsdo.org, and you can just have a look at it. If you are more interested, you can visit the Indian National Release Center, and you can actually register and download the SNOMED City also if you want to have a look at it. Coming back to Digital India, if you look at this document also is available in the public domain. So for the Digital India initiatives, if you look at it, the fifth pillar, that is eKranti, or electronic delivery of services. For that, in the health, these are the proposed ones: online medical consultation, online medical records, online medicine supply, and pan-India exchange for patient information. So these are the stated goals of the Digital India initiatives as far as e-health is concerned. And work is going on each of the fronts. In fact, there are also related things. In fact, on 15th, that is Friday, there will be a launch of a Quit Tobacco SMS program that is in collaboration with WHO. They actually had developed a mobile app which worked very well in Ghana for tobacco cessation. So now they want to scale it up, and what other ground than India? So we have it. We are going to start it in English and Hindi. Later on, probably we'll be having more languages. So there would be two ways of registration. Either you can give a missed call to a number, or you can come to the website and register. And then there would be periodic sequential SMSs being sent to you so that you can cope up with the tobacco cessation programs. So this is the concept note order, and what is being proposed for this National Health Authority, probably the Center for Health Informatics will be acting as its secretariat. So the SNOMED City National Release Center will be there. There would be health repository, HR standards, and health information exchange. And that brings to the end of my talk, but then I would very much welcome questions from each of you. So if you have any questions, I think we have some time. Yeah.
So this related to the standards, just like EH standards, there is some device, every device in healthcare has to be certified for particular standards. So which government body is handling this part? Under ML, if I'm making a patient monitoring device, so whom should I approach for its certification?
Yeah, like for imaging, you have DICOM. DICOM is the standard for imaging devices. For this mobile, in fact, the thing which is coming up, that's the IoT, the Internet of Things, because wearables, I think, is the next future. So whether it's tele-home care or mobile health and Internet of Things. So there we have some ITU standards, M2M standards, machine-to-machine standards. So those are being recommended by the TEC, I mean, from the DET. But as I said, I mean, you have to be very careful. I mean, you need to know exactly where it is. I mean, if you look at standards, I think the plug point is the best example. Wherever you go, you have to carry your own, otherwise you can't use your devices. So some of the very basic things often we don't tend to give much importance. But yes, work is going on. There's another area where in India we are yet to wake up, but even US FDA is a bit late in that sense. But Europe, UK, Canada, they already have it. That's called the software as medical device. So even medical, I mean, software itself could be a medical device where it calculates the need of an intervention, say pushing of insulin or something, and pushes it. The software gives the order. So that is a medical device, not a software anymore. So even for software as a medical device, there's a need for standards. but I think it's a slightly longer way to go for us.
Supporting that proposal which you are talking about.
Which proposal?
National Initiative for E-Health.
No, National E-Health Authority will be something like Telecom Regulatory Authority of India. So they would be giving the guidelines. So they may also push for legislation. But standards are developed by standards developing organizations like SNOMED City, ISTSDO, HL7, DICOM. These are standards developing organizations. So standards would be developed by them. Even BIS, I mean, like ISO standards, BIS would be. Right.
They will be adopted these standards.
So,
adopted these standards.
yeah. So,
Is there any government body which is taking control of this? Like even if it is a ECG machine, a new ECG machine comes up. So do they need some certification from the government?
actually, as of now, for most of the equipment, usually it's the IEEE standards which are followed. But as I said, there are other standards coming in the way, and BIS also is trying to put it. As of now, what I believe personally, I mean, there's a lack of direction because there are so many bodies all around. So once the National E-Health Authority comes in place, probably it can give a coordinated effort. In fact, the thing which I believe very much that we actually need a very cogent national e-health strategy. Unless we start in a well-planned manner, we are going to land up in a mess like the US is currently in 5 years later or 10 years later. So unless we start in a proper strategic way, then we may land in mess 5-10 years later.
ISO or BIS would be good enough.
BIS doesn't have standard for lots of them, and BIS, most of them, the ISO standards which they are endorsed by it. But as I said, I mean, there are different things like for clinical administrative things, HL7, for vocabulary, SNOMED City. If you are going for a classification, statistical classification, ICD is the standard because WHO recommends it. All countries have to give an ICD. So some of the standards are already in place. Some standards are in the making. But as I said, technology is evolving much faster than what.
So for wearable devices right now, Health Ministry has not defined the standards.
IC 62 is part of device.
Yeah, I mean, it's not wearable separately. I mean, devices, yes, there are standards. But as I said, I mean, because for wearable also, I think this M2M will be in a big way. But then M2M comes from ITU. So again, whether it's ITU or JIC or ISO, I mean, that's the point. Standards are not one.
What is the e-jails? I was a little
Sorry?
You talked about e-jails. What are e-jails?
Which one?
The slide said that.
Which one?
As part of, there was a word e-jails as part of the code.
Which one?
Yeah.
E-Kranti.
Police e-jails.
Oh, this one, e-jails. That would be under the Ministry of Justice. I have no idea exactly what is e-jails. But this is there in the public domain. This is the official Digital India document. So Digital India initiatives under different. I'm interested only here, but then all the ministries have their own sets of things. Digital India is a huge umbrella. Yes, yeah, two answer, yeah. No, programs it won't affect, but what the National Health Authority will definitely want that whatever software you use, whoever be the vendor, they should be interoperable. They should be in some standard format so that they can exchange information. So it doesn't matter who is your vendor or what software you have been using. That is all fine. Just you have to ensure that they can talk to each other, which as of now, even the NIC software don't talk to each other. They have got lots of them. I mean, it's various examples are there.
Which organization is housing this NIN, Registry of?
As of now, we are doing it. National Health Portal is actually coordinating that. The number has been generated by NIC. It's a random number. The number doesn't give any meaning.
Does it have anything to do with the Clinical Establishment Act National Register? That again the same.
See, health is a state subject. This is again a very interesting thing. So even Clinical Establishment Act, if you take, I think less than 10 states have actually adopted it so far. So because health is a state subject, as far as Clinical Establishment Act and any act related to health, they are at liberty to do whatever they want.
If you can integrate NIN with
Not just this. Even the IRD has given a unique number to about 30,000 odd hospitals, and they're mostly private. So bringing them together, yeah, we I think tomorrow we'll be having a meeting with them. I mean that needs to be, and I mean whatever be, for all practical purposes, probably it will be just going on adding some columns so that you have your number, but make sure that this number, one unique permanent number valid all over India, should be there, so that then at a later stage it's easier to track.
Just like PAN number of an
Right, right. So it will, NIN is like the UID of the hospitals. Yeah.
And you said the mobile app. Which mobile app is there? Is it for Apple or just for Android?
It's right now it's only Android, but we'll be having for Windows and iOS also. NHP, Directory Services, National Health Portal Directory Services. So we have some hospitals and blood banks. So all the NBTC, I think 2,711 blood banks which are acknowledged by the National Blood Transfusion Council, they are there. And we are actually trying to get the daily status update. Right now about, I think, I mean, we have given the login IDs to all, but I think some 8 or 10 states are only actively doing it. We have done a pilot with Delhi and Mizoram. That pilot turned out very well. Now we have given the login ID to all. So we are just trying to see how to get it on board. And ORS, as I said, the NIC, which has built this online registration system. So ORS will also be actually taking from our database and reflecting those daily status update for different blood parts, blood groups, blood parts, everything. Sorry.
So there is always a mismatch, and the single consultant, only one consultant. And it is important for providing quality emergency care. You require normally a senior level person in the emergency. And you will agree with me, when you go to a casualty for seeking treatment, you will find the junior most doctor sitting there and looking after it. Obviously, everybody wants their body to be touched or cared by a highly skilled person, whether you are at different age groups. They say, there is a famous saying, from neonate to prostate, from mild sneezing to heart attack, they all go to the casualty. And the sorry state of affairs which we have in our country right now, when you go to the emergency with various types of complaints, maybe pain abdomen, change the bleeding or you had an accident, what happens is when you go to the emergency, you become the casualty of casualty medical officer. And it is a true statement. It may be hard, but it is a true statement. As I said, junior most doctors manning the emergency. How unsafe it is. The burden of, the care is there, and the burden of unsafe care is also there. It is equally matched in our country. Burden of care is important, is there in our country, and it will be ever increasing because of population. And the burden of unsafe care is equally there in our country. And it is true fact. One cannot struggle to respond. So how to provide quality care? You have to have highest level of skill for performing in the emergency setup in the casualty, so-called casualty. Round the clock, 365 days on the floor. You have to have skill component, number one, for any industry. And it is same for, especially is so important in our setup, because just like the aviation industry, if you do one captain does one mistake, 170 or the number of patients are sitting there, they die, 100% mortality is there. Whether it was a small plane crash of Noida, the Dwarika, or a big plane crash, one error and you die. And it is similar in the emergency healthcare sector, where if the doctor's mistake or the healthcare mistake, doctor, nurse and paramedics mistake, patient suffers from morbidity or lifelong disability to death. This is, I think, everybody can understand this statement. To provide quality I worked as a junior resident. I worked as a porter who can transport, worked as a senior resident, worked as a consultant, and now I am working as a. So over 7 years, the problem was there were no other faculty in the emergency department. But I had to be there. How can I be there 24/7, 365 days on the floor? Yes, I have to burn myself last 7 years from morning 8 to evening 8. But what next? How I provide quality care to my, people in the emergency beyond 5 or 6 o'clock. Then what I thought, this is the genesis. Then how to be present without being present? Yes, I had a good system, good team I made. It was a team game. Emergency care is all about team sport. Just like you see, rewind this meeting. Just rewind yourself and see that you must have seen how Formula 1 car races, they change the tires. They change the tires without speaking to each other. And they change the tires within 10 seconds. 10 to 15 seconds maximum. And similarly, the resuscitation has to be also quick. Plus, you require a continuous supervision of a senior person who will find you, pick up the errors, guide them, so that our patient gets good quality care. So error reduction, that's why there is always a supervision, whether it is healthcare industry or other industry, there is always hierarchical system. I am sure those who are coming from IT sector also, every system has got a hierarchical system, so that we minimize the error, we pick up the error, we pick up the things which we have forgotten, so that we get a good delivery of the proper system. In healthcare, we want that no patient should be harmed at the end. That is our delivery. Plus, we give standard of care. There are two things outcome we want. So there are multiple layers which we have. So one of the layers is consultant supervision, which was required beyond evening. And that is how we came across, we started a concept of having a Skype round concept. Yes, what happens is, there is a problem people have said over the years, telemedicine is the panacea of connectivity, or giving consultation right down to the last person standing. Yes, the background is, yes, we had experiment, we have worked a lot through various technology, through ISRO and all that, but what happens on the ground? It also requires huge amount of resource, human resource, infrastructure resource. You require money for that. You have a dedicated team working there, but it is a fixed facility. Patient has to come there, especially in emergency settings. Patient unfortunately cannot come near the equipment. The equipment should be on bedside. That is the concept of emergency care. The need-based thing, patient should give consultation down there on the floor to the patient. And you will agree with me, because of miniaturization of machines, mobility of machines, portability of machines, it has become easy for us in the present era. Why not to use that? Skype is also available in my smartphone. So what we do is, this is the thing, and we have been doing over last 4 years in taking a Skype round. That has solved my purpose. Present without being present. Or you can say, oh my God, Dr. Boy is here. Let's get the things done. Pull out our socks, So randomly I'll give a call if I'm out of the station. Or till now we are also limited consultant, only 2 more consultants have joined. So we have a Skype round phenomena after 9:30 in the evening. Whoever the faculty is present now. First now I was alone, now there are 2 more faculty. So we have a Skype round phenomenon. So they take round from their home at 9:30. Ideally should be managed round the clock by faculty. Ideally. But we have limited faculty because nobody wants to join in emergency. It is a tough job. So let's take you through that how a Skype round is conducted. I will take a round through Skype. This is one of the things. You can use any other technology technical thing. The are we ready, Hansraj? Okay, now we are connecting to the Skype to the AD. We have a small. We started with a small netbook in a dressing trolley. जो dressing trolley होती है, उसमें थोड़ा netbook we use, and then I was connecting it to go near the bedside. The nurse will take, and then we give live consultation. So the resident will call me because a bandwidth problem also. So we'll mute the. What we do is we mute both ends audio, and we talk through phone. That gives a better bandwidth, and we can visualize the patient, and the resident will tell, the condition of the patient, and I give the decision. Okay, what has to be done? So what happened in the morning today? Today morning at around 8 o'clock, 7:50 a.m. there was a construction workers. Just you must have seen the construction going on in East Nagar, and 11 laborers, they're sleeping near a pit which was 30 feet, and suddenly, that all went down, and they all fell in that pit. Aaj morning ki baat. So patients are there. I hope we'll take a round for that, So, आवाज म्यूट कर दो और आवाज म्यूट कर दो and give me the mobile to that. Okay. Or else what we'll do is, Shruti, get me my laptop. There is a recorded Skype video, Skype thing. I will just show you. Is that okay? That's okay. That's fine. Audio जरूरत नहीं बोलो. Audio speaker जरूरत नहीं. And give the phone to the. Okay, we are on. Doctor. हाँ सुनो विपिन, सुनो इधर आओ स्काइप पे आओ. अरे स्काइप पे आओ, इधर स्काइप पे आओ, स्काइप राउंड पे, इधर स्काइप राउंड, इधर उधर मत घूमो, इधर आओ, इधर स्काइप राउंड पे आओ. ओके विपिन, यू कैन टेक द स्काइप, वो लो जरा पेशेंट के रेड में पेशेंट के उधर स्काइप राउंड ले लो मेरे को. कितने पेशेंट हैं? हाँ इसको बोलो कि लेके जाएगा ये ट्रॉली. हाँ चलो मूव. ओके, ये ट्रॉली को ले जाने के लिए बोलो उसको. ट्रॉली ले जाओ बेटा. ट्रॉली रेड एरिया में ले जाओ. हाँ ट्रॉली, ये जो है ना ट्रॉली रेड पे ले जाइए आप. ओके, so that is what you can see is the red area. Ashwiti, in the meantime, you just figure out the, just on करो. Yeah, इसको play करो. Can you hear me now? Okay, connect me again from your side. Already CD load है. लगा दो. हाँ विपिन लगाओ दोबारा से. Okay. So what we have done is we have recorded a Skype video, for you, so which I presented last time also. So till they get connected here, I'll just show you that. Yes, Vipin. Okay, are you on now? Connect from that side quickly. Connect from that side. Connect. Okay. So वो लगा लो. Screen पे लगा. ये लगा छोड़ दो. So I'll just show you how actually I take a Skype round, regularly on a pre-recorded, video until they get connected. So we'll show you that. So what it has done is giving real-time decisions to my resident. What needs to be done for this patient? Does anything extra has to be done for treatment of this patient and final disposition? Does he require admission? Does he require transfer out? Does he require any other super specialty consultation? That is done. So I'll tell you the benefit of this Skype concept. We presented recently in AIIMS WHO collaboration, which I have recently, in strengthening emergency care at the primary healthcare setting, where actually now the strength of our country is the right down at the grassroots level, where actually doctor is not there. Doctors are there, but they are not there in the primary healthcare setting. Let me tell you, in district hospital, we have visited many district hospitals. Yesterday we were in Arunachal, and they are there, but they are not there. But who is there is a nurse which is available there all the time. And the good part of it, it has got a 3G network. Even in remotest village, with no cost and low cost, you can really give consultation from the higher care center. From Guwahati, I can give a consultation to Arunachal. That is the, I'll tell you the, extrapolation of this concept to the remotest setting. So this is what it is. Connect karo. Connected hai? Okay, but I am unable to see. Yeah. Are you there? Yeah, live connectivity also there. Okay, you are in the red area right now, Vipin. Okay, so what is the patient like? Oh no, don't show that. It is don't show that, but you can just talk about the patient. So it is a 24-year-old male patient.
He is a bike driver.
Yeah.
Had a head-on collision with cow, sir.
Okay.
At Indrapuri at around 12 o'clock, sir.
12 o'clock. What are the?
Brought my family relative.
Okay.
Michael collar applied. In breathing, air entry are equal, sir. Respiratory rate 80 per minute.
Okay.
And in circulation, BP 86 by 86, sir.
Okay. What is the GCS?
In D part, sir, GCS equal 5 M6, sir.
Okay. Pass positive, negative.
E-fast negative, sir. Patient is waiting for chest and pelvic X-ray, sir.
Okay. Okay. So okay, take care of the patient. Then move to the bed number 2.
Yes, sir. Patient number 2, sir, is 45-year male patient, Mr. Pramod.
Yeah.
Yes, sir. He is a bike rider, had a head-on collision with cow, sir.
Okay.
At sector 18, Faridabad, sir.
ABCs are all right.
Yes, sir. He is initially taken at Sarvodaya Hospital, sir.
Okay. ABCs are all right now. ABCs.
No, sir. He is already intubated from there, sir.
Okay. Intubated and referred here, right?
Yes, sir. From Sarvodaya Hospital.
CT head done.
CT had not done, sir. Patient just received, sir.
Oh, you just received and sending for CT scan.
Yes, sir.
Okay.
Negative, sir.
Okay.
Chest and pelvic waiting, sir.
Okay. Okay. Now move to the next. Okay. No, continue. I think your red area is quite busy. So we will just skip the, that's enough for the Skype round which we have. Okay, and we can just move to the yellow area.
Yes, sir.
So my red area, which is research is quite busy. I will not be able to take you through that. Some sick patients are there. So I can see the whole emergency department from here. Okay, and you can give decisions locally. So thank you, Vipin. I think we can disconnect now. For the interest of time. So thank you very much for your Skype. Right. So that was my nurse actually, trauma nurse coordinator who coordinates and he has the details of every patient. So my residents ABD I also take round with them because my residents ABD I don't want to disturb them. So you see, and there's a video which see how it is played. Can you just play this? So this is what I can do from taking it down from my this plate. So you can see my resident we're talking there, and from both sides it has been taken. This is from my end, Yeah. So this is what you saw just now also, and this is a pre-recorded screen which I have, which I am taking. Every patient's detail is given. The round is given by my resident there. Okay. So this is from my end. I am giving decision. I will show you the other end. From the resident perspective, you can see there. This is from the emergencies. Video has been taken, recorded from the. So here I am able to see my patients as well as the vital details. Suppose you extrapolate this consultation, as I told you. So what happens? Suppose I extrapolate this concept to remotest setting in primary care or in austere environment. Austere means where you don't have anything. 5 countries: Maldives, Myanmar, Sri Lanka, Nepal, and one more, Thailand. Thailand, they already developed, they're doing on their own, but not this concept. So they are also, like the concept. So that is what the beauty of this kind of thing, where you can give live consultation to the remotest. And now there are various technologies, like you have WhatsApp and all that. Dr. Deepak takes this consultation as a neurosurgeon through WhatsApp. They send the images and videos and images in a CT scan, and he gives the decision whether to operate or not. So it gives a huge impact. So there are various this technology which can empower our people in the rural area. So where we talk about the what is called as basic digital requirement, and is a necessity. Like we have air, water for regular drinking. Now what is called as basics, internet basics. It has come recently in paper by Facebook, supported by Facebook, that campaign. So similarly, pre-basic, sorry, I'm not ज़्यादा literate नहीं हूँ आपके तरह IT में, but कहने का मतलब है कि this is what it can improve our care at the rural area, because 70% of our population in the region, not only in India, lives actually in the rural area. So this may have far-reaching ramification and things which can empower decision making and this thing. Thank you very much for your attention. For technical questions, now I invite Dr. Deepak, technical questions. So you can ask him the technical questions. Clinical questions I can take, because he actually, I asked one day that how I can be present in the ED without being present there. So I asked him, can I use through Skype? He said, yes, I will make it happen for you. So that is how we got it done. And he's my good friend. That's why when I keep on, poking him, he gives me some good ideas. Thank you.
Thank you, Dr. Boy. That was a very interesting talk. And you have seen there is a difference. The technologies are there with us. We have expensive proprietary technologies also available for telemedicine. And we have very inexpensive or free to use technology, which we use every day, but we do not use it for commercial reasons or for actual use of professional telemedicine. Because if you see the last mile connectivity, which is the bandwidth, if you improve the bandwidth, everything will work very nicely. It doesn't make a difference. However, even proprietary will fail if the bandwidth is low. Although people say of various kinds of compression algorithms, even if you see Skype or Google Plus, they also have the same compression technologies, because they have to in fact work over dial-up networks. They know the problems across the Africa and Indian subcontinent is broadband speed. So they also have developed, and in fact they are leading the pack right now in terms of compression technologies. And you saw what we have a good internet here, but because it is being transmitted, the quality comes down here also. So what we have done is very simple again, that we use the phone, regular phone line for audio, so that the voice quality remains very good, and the video just to get an idea. Because if you have these two things coming in, then it is a satisfactory, I am not saying ideal scenario, but it's a satisfactory way of doing telemedicine. And we have been using it very successfully, and it's a very nice model to use. In fact, everybody has Skype on their phones also, Google Plus on their phones also. So you can actually have a video conference without any equipment. And we've been doing that. We have just kept a laptop there, but you can use anything you want, and it works very nicely. So it is just to open your minds that unless you have very expensive telemedicine equipment, you cannot do telemedicine. It's a myth. And as Dr. Bhoi said, even today, like telemedicine is a very vague word. In fact, I receive around 2 to 3 consultations by email from people who find out my email address on the net, saying that we have this, we have that, what would you suggest? So I answer. That's also telemedicine. It's on by email. You're sending pictures, your CT scans, MRI, everything by email, and they expect me to answer. This is service, community service I do, and I think every clinical consultant in AIIMS must be getting these kind of emails. So if there are around 500 clinical faculty, you can imagine the amount of telemedicine we are doing even without knowing it every day. And then WhatsApp. WhatsApp is if they get to know your number, they will send. Nobody bothers about privacy or anything here in India. They will send all images, everything to you. Ki, Dr. Saab, please let us know what is to be done. And because it is such a societal way of doing things in India, that even the distant known tools will send images. Everybody will send images, and through them they get the connection. So we are doing telemedicine in a way which is very abstract, which is not documented properly, and doing it every day of our lives. So this formal telemedicine becomes actually a problem, because nobody has the time to actually sit down in front of a screen and talk to patient. I would rather just see the images and an answer on WhatsApp or on the email that this is it, you come to my OPD or don't need to come to my OPD. Very simple. And that serves better. Because if you sit down with a patient, I'll tell you the practical problem with telemedicine. If you sit down with a patient, they will have 100 questions to you, and they will take so much of your time. You have this much amount of time for 10 patients. If you start spending 10 minutes, 20 minutes with each patient, you'll not able to do anything. But by email, you can give very concise answer, yes, no, this to be done, not done, and that's the end of it. They cannot keep bothering you. Otherwise, they will know that you will not answer. So every technology has its uses and I would say disadvantages, and that is why we prefer unidirectional interfacing much more. That they can send data and they don't know if they're going to get data back or not. But here you are stuck. This, I would say, is a perfect way of using it, that you are having it in an official professional environment with your people. So you have complete control over the environment. You can talk as much as you want, whenever you want. And for emergency departments which are associated with AIIMS, we can do the same thing. Okay. So Dr. Bhoi has been doing it with me for a lot of time. Any questions? Yes.
So we have some plans right now with city cable at 100 Mbps. So speed and bandwidth. What's the difference?
See, 100 Mbps might they be saying they are giving the bandwidth. Like NKN says, you have 1 Gbps at the backbone. That is what they are saying. But when it comes to you, finally the last mile switch bottleneck will decides the actual bandwidth. So if you have a switch which is not 1 Gbps, is a 100 Mbps switch, your bandwidth automatically restricts to 100 Mbps. Or your internal LAN is just 100 Mbps or 1 Mbps, it restricts to 1 Mbps. Now after that, 1 Gbps, what people say is, that is the bandwidth of the pipe. At the end, where the internet service provider is, might be providing only 1 Mbps speed. So although the bandwidth of the pipe is 1 Gbps, speed you are getting is only 1 Mbps.
If both have that 100 Mbps, then fine.
If the ISP is giving you 100, which is not what when they say 100 Mbps, it's not a leased line. You have to understand that. So it is being not shared only, it is shared over 10-15 customers. They have certain policies in place. Sir.
Maybe slightly audacious and invite Professor Reshim Gupta to he's Professor Emeritus from IIT Delhi in networking.
So he can answer better. I am talking from a lay person's.
Can I invite Professor Gupta?
Sir.
Yes. And he's my teacher also.
Actually, what you said is perfectly correct. It says big pipe finally. And how do you distribute that pipe into multiple streams? Technically, it is like this. And it is a usual practice for the ISP that they aggregate. That multiple customers they will put in the same pipe. Assuming that the activity level is 70%, 80%, 60%, whatever that level is. That's what he was referring to the policies that is. Okay. And also, if you are willing to pay more, I'm saying pay, and you have a contract, then they will have what they call the advanced resource reservation. Okay. For example, you want to go into emergency situation, you want to do high resolution graphics, you want to send something like that. Then you please contact them earlier that give them the I want the resource bigger. So therefore they will give you bigger pipe thing. That's the kind of thing. This interplay is there, finally it will end up in giving you spending a little more money. So it's a question of again how much you wish to pay, what whether what kind of compression you wish you are able to accept it, good granularity or very high quality and all those kind of things. They all come together. It's not a very simple question of that ISP. And what you are willing to accept.
So now I'll just invite Dr. Kiran to hand over memento to Dr. Boyle as a token of our appreciation for his talk out here.
One question is, which is a legal issue, when a surgeon or a doctor is supposed to be there and he is not there and guiding, how much is the legal action in that? We know there are floor doctors and all are there, but a consultant's presence, maybe X or Y or Z.
Sir, you have a very valid question. What I can answer is, in US also this was the same scene around 10-15 years back. Because of certain legal issues which came up, they changed the scene. So now they require the consultant to be inside the OR the whole time when the surgery is going on and things like that. But it has not come to India. So legally we are clear that we don't have to be standing there if there is a qualified doctor inside. That's the qualified could be it's a post MS, it's a surgeon. It's a post MS, it's a neurosurgeon. So that is there. Because we understand that India there is a huge resource gap. One senior person cannot be there for everywhere. So in a lot of places in the world there is one senior surgeon who is operating 10 ORs. So he is jumping between the 10 ORs. Junior people are opening up the patient. He goes in for the critical part and comes out and goes to the next one. So that's very common. A lot of European countries also do the same thing. US they have stopped recently. Recently means around 5-6 years back. Before in the US also it was the same. But now they have doctors, so many, a lot of malpractice, suits are there. That's why they stopped. So for brevity of time, I'll just go to the last topic before lunch. And this is something which this was a DBT funded project. Actually, this was a we got a fellowship from Tata DBT fellowship, and the idea was whether we can use some automated way of assessing hand hygiene. So I have with me Aarti Dhiman and Munish, who are there from one of the private companies and who are supporting us in building a prototype. A prototype means the whole ecosystem of automated detection of, and this requires a lot of data collection and data analysis at the back end. So I'll just quickly go through my part and then I'll invite them over to talk about the technical parts. So if Aarti and Munish can raise their hands, everybody can have a look that they are there in the crowd. So I think all of us understand that hospital-acquired infections are the most dangerous and in fact the most problematic for patient outcomes in any hospital setting. And around the world, hand washing is the only way. No other way has been still documented which has been proven to dramatically reduce the infection rates. So that is well known, and we all know that why it is important to hand wash, what are the various ways of doing hand wash. However, despite knowing everything, in the US, in the developed countries, hand washing rates with the strictest surveillance, manual surveillance or whatever surveillance is there, does not exceed 60 to 70%. Okay, so 30-40% people are not hand washing, and I'll just rush through this. People have been putting their minds on how do we improve the compliance rates. Now what happens is, what people are usually doing is to somehow motivate the healthcare workers, because they found this is the only way of motivating them, like a patriotic feeling that you have to die for the country. Similarly, you have to get a feeling inside that person that you have to hand wash. It's very difficult because a country and a patient are completely two different things. But this is what they plaster the walls with advertisements: hand wash, everywhere you have sanitizers, you have this and that. But what I found out was it's very easy to somehow ignore. Your mind is such an amazing thing that the brain stops registering any of these. I can give you my personal example. I was taking around in the ICU. I got a phone call. So they asked, where are you in the ICU? I said, how do you know I'm in the ICU? He said, we can hear all the alarms beeping in the background. Every single monitor vendor, we have all alarms, and we don't register them because that's what we get acclimatized to them. And although every single alarm is going off from every device in the ICU, the alarm should not be going off somebody's, but in India nobody bothers, they're going off all the time. You don't register. It's like they never existed. So you continue with your round, you do everything without even bothering about them. This how it's the amazing capability of the human mind. Similarly, for hand washing, you may keep thousands of posters and do everything possible. They stop registering. So it is of no, except for taking up real estate and making it look like as if somebody's got a painting competition going on. It doesn't help anybody. See? So you have to have various ways of improving, and technology is one way. So people have thought what is to be done, and how do we actually improve the hand washing rates in a complex environments like the wards, ICUs, and other places where infection can be there. So it's not that we had caught of a unique idea. People have thought about it, like barriers that you can only enter after this. But all of these things have never really taken off. And with batches which tell you, that which are monitoring compliance. So what we thought, all of these depend on the individual to really help in doing this. We wanted something which works in a automated manner. Okay. So we thought of maybe we can think of something as a cost-effective solution, and which does not depend on the individual to decide or to make them motivate to do. And finally, the data, either we say that you have not done this, you better improve, or you will be removed from this place. That's the only way to ensure that people are doing it. So we wanted to have an automated monitoring system, and what we did was we took the help of IIT Delhi. We had Dr. Biswas with us, and they actually, what our idea was to use Kinect. Okay, and Kinect everybody is familiar with. It's a Microsoft Kinect which is used for playing video games. It detects hand motion. So our initial idea was, if we could detect the motion of hand washing, which is this pronation, automatically, we can detect how many times the the healthcare worker has hand washed, and somehow get it into automated fashion into the system. And obviously the sanitizer next to each bed, how many times they touch and then hand wash. With identification of the healthcare worker, it would help us. So IIT Delhi, they helped us, the Department of Computer Science, they helped us a lot. And this was going on for a couple of years. Then there is another vendor we came up, who the one I just talked about, Munish and Aarti, and they have been using Kinect for a lot of other things. So one of the things they have been using Kinect is for packs. This is a very interesting application, although I will not be showcasing here, is touchless packs. So they already have a commercial solution for that, in the sense that if you are scrubbed or you're operating, you cannot keep opening packs of that patient and looking through the various images. So using Kinect, you can just gesture on the monitor and it will show the relevant images, and you can scroll down, scroll up, zoom in, zoom out with your hand action, because Kinect is controlling the packs and you're detecting your finger. So very nice. It's like a video game, but actual patient related. So they told us that they'll be happy to just see whatever IIT has done and build on it. And we said, okay, fine, because we are already collaborating with IIT. So they also, because they said they already had a solution for a different application. And so I'll call them over. I will not, because the technical things, I think they will. So I'll ask Aarti, and Munish can also come here. to tell us what they have done and what they did from whatever IIT Delhi had already set up to come to a stage where we can now say with confidence that yes, we have a working prototype available. Manish.
Thanks, Dr. Deepak. Hi, everyone. My name is Munish, and I run a company called Gesture Research. And so Gesture Research is all about computer vision and gesture recognition technology, and we primarily research on finding use cases for using the technology for helping people. Right? So, and Dr. Deepak came up with a very noble idea of saving lives using our technology, and we thought, yes, this is what we need to do. And we looked at the work done by IIT. That was a wonderful piece of work that was already done. So I'll quickly come to the system, and we already understood how important hand hygiene is and what are the problems that are faced in a healthcare scenario, because and it's about people primarily, but people working in the ICU, they have a lot of work to do. They have a lot of things to take care of, because it's life that they are saving. So it's not a mistake. It's something. It's urgency. We need to take decisions, and we might forget things which are important at times. And this happens to everyone. Maybe in an accident situation, I might even forget to call someone who is standing nearby, because it's a situation that I'm facing. So so we came up with an idea, or the idea was already there. We actually taken it forward. To use computer vision technology to track people in the ICU, and we placed. Do you see this camera, Kinect camera, marked there? So this is for the people who don't know what this is. So this is a gaming camera, and this was earlier used for motion controlled gaming, and the technology it utilizes is body tracking. Where the complete person's body is tracked, and the body is marked with different points, telling where person's hands are and where different parts of body are. So we use the same technology, and instead of using it for game, we started tracking nurses in the area who are walking around, or the doctors, or anybody who is walking in the ICU. Okay. And there is another part to this system where, utilizing computer vision, we can identify a unique identity card given to everybody in the ICU. We can track who that person is. So we can track the body, we can track who that person is, and then post that we track all the movements done by that person. And the system specifically looks for two things. One, washing hands, one, touching patient. So if I'm a nurse, I come to ICU, I touch a patient without sanitizing my hands. So the system will send a non-compliance entry by my name, because I'm identified with my ID card. So the system will send an automated entry to the system telling there's a non-compliance that happened because of me. So, and we track that information. The system pushes information from each and every bed, tagging that this bed, this person came, washed hand and touched, or this person came without washing hand touched. And then all that information is consolidated in a central database. So this is how the system is set up. You can see there's an ID tag, there's a hand wash station, there's a bed area, which is all tracked by the sensor. And post that, all this information is tracked, and from all the beds, the system is pushing the data to a central data store. And this can be expanded to multiple ICUs, to complete healthcare institutions. Maybe if you have multiple hospitals under an institution, the compliance reports can be consolidated to a central database. And then finally, these reports, all these consolidations are presented on a web-based dashboard, telling the compliance level of hand hygiene throughout the institution. And this is a trigger, right? So we all studied in schools and colleges. End of the day, it's a report card that we worried about. That, what's in my report card? Am I the first ranker? Am I getting the maximum scores? Did I get at least the first division? And this is what people will look at, and then think through, okay, I didn't wash my hand this many times, because we are giving multiple reports telling the patient, the bed-wise and nurse-wise reports, telling, if there is a nurse who is, for some reason not washing hands before touching patient. So those names are highlighted here, and maybe we can talk to the person and understand the problems they are facing to comply to the hand washing activities. So, and maybe, if required, take strict actions if somebody is a repeat offender. So that's the system, and it's a very small and sweet system, but the computer vision and the technology behind is working in a novel way. So that's what it is, and maybe I can play a small video here which can show what how this system is functioning. Can you help us? This video. And this is done on a dummy because we don't want to disturb the patients there. So you can see the person coming. So there's an ID tag, and that person is tagged at nurse P. The dashboard was blank, but if you see, there's a non-compliance entry because the person touched without washing the hands. Yeah. Let me just do it again. Okay. So initially, no entries, right? So as soon as the person comes, so there is a tag. The person is identified as nurse B, and he touched the patient. You see, there's a non-compliance entry on bed 1 for nurse B. Okay, and that person goes away. Just a live video recorded a little slow, so we can wait for that. So here, this was a clean scenario where the nurse came, washed hand, and so you see the nurse coming. So there's a hand washing station here. She is also not clean. So let's send a non-compliance entry for nurse A as well. So let's look for a clean entry. So this is the hand wash station. So hand wash happened. And now the patient will be touched. No entry for this person because he's a good person. So that's in a nutshell what the system is doing currently. And this report is presented on a web-based dashboard. So this can be accessed from anywhere, so that different authorities can take a look anytime, real time. So
it was a hand wash gesture kind of a thing which was recorded by Ethan, right?
The hand wash is recorded by the computer vision.
Kind of action, motion was recorded.
So not this one right now. So we are taking. So maybe I can.
So it is not sensing the correct measure, right?
Yeah. So it's a prototype. So
this is not being recorded.
What is recorded?
The person, the hand wash station, the sterilium bottle is kept there.
Okay.
So when your hand goes near that sterilium bottle, it records one, and when it crosses the bed boundary, it records it.
Oh, that's
so because the bed boundary is marked on the computer, actual bed is marked on the computer, and the hand wash station is marked on.
So when you go near the hand wash station, that's recorded,
and when you
yeah, and there's a time frame that you need to be. So if I just move my hand, so it will not recognize.
It's a RFID tag?
No, nothing on the patient. Nothing on the ID. There's a paper.
Just a paper. What is it called? In front of it?
It's called a GILF.
It's called a GILF.
If obstruction comes in front of it?
So it is recognized once. So if once it is visible.
Let's say it's maybe a wireless. So let's say the radio frequency will do not pass. Let's say if an obstruction comes between, what will happen?
I'll answer that. I'll tell you. I'll answer one by one. What is this GILF thing which they have done is, it's a kind of a 2D stuff. So once you are in the view of the neck, line of sight. So once you have to come in line of sight to register your ID. So you are identified a nurse, say nurse, whatever. Once you identified it, you can remove that GILF and throw it away. So it will cut, because once you are in the line of sight or under that whole area of the kinect, you have been identified, your skeleton has been tracked. So your skeleton has been identified by the kinect. So you can continue doing, gilf has no more role. But if you go out of that area and come back again, you will again need.
There is a fixed track which is to be followed?
No, there is no fixed track. There's a, I would say 6 feet by 6 feet area for each kinect. You can correct me if I'm wrong.
It's basically a 8 meter and 140-degree wide angle.
Which
So
fixed track.
it's particular line of sight area where
So
you
this
can
is this is a proof of concept. What is the second step? There are 2-3 things we want to do. One is to actually capture this motion, because that tells you that it is actually hand washed. Because right now we are assuming that he touches the hand wash station and crosses the bed, so either he is hand washed or not hand washed. Whether he touches. The second thing we want to do is, we already tested it out that we have 2 or 3. We have a like cell towers and multiple. So you cross from one cell to another cell. Your phone doesn't lose the signal. You continue talking. Similarly, if we have an array of kinects, one across every bed, they will talk to each other and by the software. So then it becomes a seamless. So you're going anywhere in the ICU, it remains, you are being tracked. Any patient you touch, the system knows. So right now it's on one patient, one kinect. This is what it is.
Yes.
So that's what, this is where we are currently.
Yeah, but I actually want to comment and really great idea. The reason is it is like auditing. Actually, it will reduce all these paraphernalias. If you are watched, then person does not do.
Yes.
It is the bad habit of
precise
somebody.
reason.
Hence, too much complication actually is not needed, and
Why
this
you
is a
are not
very
using
cheap process.
sensors in case of this? Let's
No,
flow
this-
sensor.
That is now that what
Do that. Let's sanitizer. The sanitizer. So sensor that once it is on, that will go
Sir,
down.
we thought of all that, but we wanted to keep something which is independent of all this. Because sanitizer, sensors, there's so many things. Then you have to monitor the electrical supply, sending a signal. We wanted something which can be done easily.
Yeah. So
The
so
other
this
thing
can
which I
be
just want to
configured.
tell what she has brought across, and that was our idea, is that if we have a dashboard, big screen of TV which you see there is there. We want to, we have already put a big screen in the ICU. Even if they are false positive, even if they are false negative, doesn't make a difference. The person on the ground is seeing that something is being recorded. You understand? And it is a psychological impact. So he might complain that, look, I hand wash is not coming. It's not coming there. That's a different thing. But if he is not doing and it's coming, he is not. It might be false positive 20%, 30%, 40%. But even if he is not doing it regularly, it will record something. So we are not looking at how accurate it is right now. I think just the tool showing that he comes into the screen and something records on the screen in front of him gives such a psychological impact to the nurse and the healthcare worker that they will think 10 times before going in and touching the patient.
Big Brother
It's
system.
a,
Big
yes,
brother, absolutely.
exactly.
And in an automated way.
And it's much cheaper as I look at it.
So your name comes, that nurse or Dr. Deepak, not touched. Right now we have not written not touched here because we want to make it a little diplomatic, but tomorrow it will come not touched. Because, and it can have legal ramifications, that's why we are keeping it. Because patient's relative also come in, everybody comes into the ICU. Tomorrow they will say, oh, my patient there, so they're not touching. And then we have a suit against us. So we have to couch your words. Whatever you do, you have to do it very in a way which does not harm the system.
Off the cuff now. You can also give a small device to a person, a deep device. Okay. The feedback comes immediately.
Yes, that is also an
Now I'm just doing it off the cuff just now. Okay.
And it also adds to what you call patient experience, upcoming series,
Yes, that is
patient
true.
engagement.
But we wanted something which we do. Right now we have to still put in the guilt. I would have loved something in which they have some face recognition or something that or totally automated. That once you register in the ICU as a person, like a fingerprint or something, then you don't have to register again. You come in and you are automatically tracked. But you have to take the first step before you can take the next step. So this is where. Anything you want to add?
No, we are close.
How could Aadhaar help in this? Everybody has an Aadhaar card.
See, I don't know because right now Kinect, the model skeleton must be unique, like a fingerprint. But right now there is no skeletal database.
And it identifies each and every skeleton in its own unique way.
Yes, it tracks it, and it tracks the skeleton. So tomorrow if we can have a way, but that will be a different project altogether, massive project, where we can identify the skeleton, give it a Aadhaar kind of a link, and put it in the database. Then you enter the room, your skeleton becomes tracked.
So you can use simply RFID tagging again.
So we are using that, something like that. Even not even RFID, this is just a GILF, which is very simple.
And what kind of information system is this? Is it like a standalone or integrated with an EHR?
Right now it is standard.
Standalone.
Completely standard.
Okay, so that's another different audit committee like that.
So tomorrow once we get it up, then obviously we have IIT, we have everybody. Well, right now it is the, see, vision crystallizing into an actual running, that is the biggest thing. So this is where we are. Aarti is there. She's with Manish, and they've both been coming here and doing it in a completely free of cost because we don't have any resources. So I think it's we should thank them both for doing it. So if there are no more questions, I think we can break for lunch right now. And
I'm sorry, Deepak, to interrupt. Before, I mean, I've been wondering that we know who have been speaking here, but we don't know everybody who are in the audience. It's a small audience, of course, but can I request?
Yes, I think that's an excellent suggestion because we are not too many people here.
Yeah.
We can have a round of introductions.
Yes. So in case comes here in the front, that will be better.
No, you can speak from there on. We just
Dr. Biswas to come over and share what we have done. इससे कर लो
ये रिकग्नाइज कर रहा है कि नहीं कर रहा है
So we are having
ठीक है ओके good afternoon everybody. Well, this is slide put in by Dr. Agarwal. It's about says that medical errors such as indiscernible prescriptions cause the death of 98 patients or 90,000. It's hard to read this. In any case, we are supposed to report this or repeat them, So while writing, people make so many errors, and this may lead to very adverse things, So key question is, who's to blame and where the negligence comes from, So unsafe practices associated with 70% of injection admission in our country. On average, 1 in 10 hospitalized patients suffer from medical errors. Half the medical errors are considered preventable. And the main sources of errors are cognitive, procedural, or affective ones. So, as Dr. Agarwal immediately said, that depends on the doctor present at that point in time. Doesn't matter how good hospital is and what is the band of doctors they carry. It has to do with good cognitive functioning, reasoning, not in general, but at that point in time. And healthcare professionals, of course, have the highest level stress in complex environments like emergency rooms, where this patient is just come in, and in ICU. Also, people have been talking about how doctors feel. That also has to deal with do with the patient's success. But one thing that people agree is the stress is always a topical issue. Any mistakes or errors can be very costly and sometimes irreversible. You cannot say, oh, can I go and correct the mistake tomorrow? It's not possible because the thing is done already. And so doctor must be in a perfect state of mind, devoid of morbid worries and anxieties. It is not possible always because
he is also prone to stress because of the peculiarities of the work situation and what the society is expecting of the doctor here, particularly in emergency situations. So we have made a small attempt to indicate if a doctor or nurse is under stress in such a situation, so that if possible he or she could be replaced by another healthcare professional to handle the emergency. Many times doctors don't report stress, they go for one duty, come for another patient here. So if the doctor reports stress, then of course he can be easily replaced by somebody. And there are some people who always work in stress only, So is it possible to categorize these people into stress and non-stress? That was one of the studies that we wanted to do. And to do this, we propose to do it through measurements made from wearable sensors. So our study group was doctors, senior residents, and nurses attending to the trauma patients in the red area, where the patients come in at this particular trauma center itself. So as you can see that the doctor is supposed to wear a belt around his chest, and all the data, I talk about what data we pick up from there, is being sent through this Sono2 wireless watch, and is being recorded on a laptop with a nurse standing standby. So these are the events for which we do the recording. Patient in a red area, CPR, doing CPR, suctioning, intubation, and for the nurses doing cannulation, suctioning or intubation, we measure their cognition state. So monitoring is done through these parameters: heart rate, energy, IBI, and body temperature. And these are done for specific periods of time. Patient in red area, 30 seconds we watch. They take CPR, 2 minutes, suctioning 30 seconds, intubation 2 minutes, and we do it for normal and both in the stress state here. Similarly for the nurses, we do for the patient entering, cannulation, suctioning, and intubation for the period specified. So this Sono2 watch sends all this data to a laptop where we have an Excel sheet in the particular form which records time in 2-second intervals, energy consumption, heart rate, temperature, and IBI data being recorded. So we do it for specific time because this is patient entered the area unit, the system starts functioning. Besides, we have a activity form which has the particulars about the doctor, was your night duty, was your proper sleep, is it fever, headache, tired, is he under stress, and we ask the doctor to put a score on his own, voluntarily. And then we have also got the time activity, time for each of the activities recorded from which point to which point in time this thing was done. And then we use this data again for further work. So goal is that we want to find out some value range for saying high cognitive risk, low cognitive risk, or medium cognitive risk here. From a data, can we make out a cognitive profile of individual doctor or nurse? Because if we can observe him for a longer period of time, we can build a model for that particular person here. And then we can use this to assess the stress of the particular individual. So we have the data is initially a bit noisy, so we just remove some noise from there, normalize it, and then we use two kinds of features here. Either is a single timestamp approach, then each row of the Excel sheet is recorded as an instance, or we take a group of continuous rows, treated as instance, we take sequenced timestamp approach. And the events that we specify for our work is normal work in the office without visiting the red area, patient enters red area, what is the feeling, then normal CPR, normal suctioning, normal intubation. The normal means person is under normal workload and is not stressed. And we do the same thing when the person is under stress. And similarly for the nurses, nurse is without stress, the functioning is done. in the morning or the off time, and then when the person is actually in the area, then we again the reading is again done from this nurse's recording only, and you find out the nurse's test, what are the values for that stress CPR was a normal CPR, stress suctioning was a normal suctioning, and so on. And the data analysis we do using some kind of pattern recognition or machine learning techniques. One technique that we have used here is known as the support vector machine. We use the binary classification, yes and no type, or even one class, it belongs to class or doesn't belong to the class at all, and a simple statistical analysis of mean and variance based measures. So suppose some 2D profile is there in which we have the normal events being shown by these 4 points here, x1, x2, x3, x4, and the stress events are there, x5, x2, x8, and we want to build a decision boundary between them. This one with that boundary can be drawn, and this boundary as it appears to be very fine because it's able to separate the normal from the stress events here. However, there is a better decision boundary compared to this one, and which happens to be this one. So this decision boundary, the difference between this one and the previous one is that the margin here, as you see, below the decision boundary and the two margins, the two sides, the margin is better here in this case. It's more than the previous one here. And if we look at two together, as you can see now, if you have a point just above x5, it will be misclassified as being normal event, whereas the one which is the inclined decision boundary will properly treat it as a stress event. So we have a point near x5, slightly up on this side, it will be misclassified by the first one decision boundary, but this one will give a better decision boundary. And this is what the support vector machine does. It tries to find out the support vectors, the points which actually separate the two groups here. So x5 and x6 on this side, and x2 and x1 on this side, they separate the two groups from normal and the stress events. They are limiting conditions. And if you take a margin based on that, then it will be the best margin available for us here. And then using this, we can give a new point. The new point is given. Now, our equation is there with us, and we can immediately tell which group it belongs to. Once you've identified a W and B, we can figure out that it belongs to the normal event or the stress events here. So, support vector machine can be used even in situations where the points are not linearly separated as cleanly as before, but they can be overlapping also. Like in this case, you can see two classes here, the circles and the filled squares, the two classes, and no linear boundary will be able to separate the two groups here. But if we use a nonlinear support vector machine by which we can take all these points and map them into a higher dimension one, then in that case all the points nearer to the origin, they stay there, and the points which are the black ones here, they shift side to one side here. And now we can take a plane in between this three-dimensional now here x, y and z, three-dimensional plane, and we can find a sneak plane which separates the two classes here. So it seems that many of these problems here which are overlapping can be easily transformed into a situation where we can find a linear separation in them, either in a higher dimension or through some other Gaussian kernels here. And so you get higher accuracy of testing. I mean, it corresponds to higher discriminative power between the events here. So what we want now, we say that what can a value to the high county risk or this thing, based on the accuracy now we can give a value to each of these risk factors here. Another way of looking at it is that instead of specifying normal and abnormal here, we look at it from a single class SVM here. The reason being that we have lot of data available for normal activity, but very few for abnormal activity. So in that case, it makes sense for us to say, okay, this is a group, and everything outside the group you let us know that will be abnormal from here. Okay, so suppose a point which is most dissimilar from the underlying distribution, which is at the origin here. All you want to know now, what is support vectors for this, and how do you get the decision boundary in this case here. Okay, so this is what we want to maximize from here, minus b by w, the distance to the points here, and then there is a solution available for this one class SVM also as well, which just tells us if anything is outside this normal group people here. And you can see the support vectors here are in this case. And of course we have the statistical measure as well. I mean, we see the variation, mean of, let's say, all doctors working in the trauma center here. We get some values for them, stress values, and then you can see how much the person is varying, whether the person is stressed and non-stressed, and how the doctor is different from other doctors in the same group. So we have single timestamp method in which we take one sample, which is one reading at a particular time, and then these are the data points for us here. And we examine variations among the important events, for example, normal versus CPR for doctors using Gaussian and linear kernel here. And as you can see that accuracy is higher if we don't use this linear kernel but use the Gaussian kernel in this case here. So we get all the attributes put together, you can naturally get a very good separation between the two, normal and CPR 98%, and if you use a linear kernel you give only 53%, which means their data is not very linear separated but they are mixed up. And if you just take fewer number of parameters, then the performance that you see on the right hand side here, naturally you will try various combinations and see which one will give. Is it necessary to use all the four, or you can just use one or two for our work. Similarly, this is for the nurses. Again, you see the Gaussian kernel performs better than this studies here. Then it is a multi-class. Now we take all the events together and find how things attribute, all the attributes are taken, then how the accuracy changes for patient in red area, intubation, and CPR. Then this again for the nurses case. Then the sequence time step, we take the sequence together, the 10 timestamps together as one piece of data, and that is used for our work here. And suppose we've taken 20 timestamps here, we just want to find out, is it exactly the same, or at some point it makes a difference here. Like in this case, we found that the x-axis is the stress value here, and time interval, and then y is this interbeat interval here, which says that interval is, you see, becomes smaller at when the person is under stress. In this case here. And similarly, we had significant difference only at that step, only 15 and 20 timestamps. And similar thing was observed for nurses also for cannula generation. Okay, so we built a software now, and this is a GUI for that. We'll show you a small demo also for this one. And there's a buttons are available. We can enter the data for a new doctor. The records are stored here. We can add for a particular model which is there. We can add new data to it, we add new doctor to it, you can predict, we can check the trend also, how the person is behaving on different time stamps, and either doctor or nurse can be selected from here. So for our pattern recognition, we consider these events for the normal CPR, cannulation, intubation, patient entering, suctioning, and similarly same conditions under stress. So by Yamuna Prasad, he is been working on this particular project from the beginning. Now he will tell you about what is the interpretation of the various graphs that we see for our trend analysis.
So basically this is a representation for result for ID4 data. So this is a doctor 4 basically, and here the graphs here. So the doctor said black one is that doctor has said that he is in normal state, he has no stress. And the blue one says that doctor has already said that he is in stress, and the recording has been performed. And this is basically the mean and standard deviation statistical measure. So the mean is observed from all the data set that is available, and then difference from that mean is captured out here. So for black one, see here at 0 time stamp. So on 0 time stamp means there is a day where he has performed the duty in normal and stress state. So it is showing that this is very near to the normal state, but while in the time stamp 1, that is the next day, he said that he is in normal state, but the model has said that he is very far from the mean of the already available data. And while in the first day also, second time also, he said that he is in stress, but he is performing well because he is near the mean. So here the point is that in the form we are keeping the stress score. So that is basically on 0 to 10 rating. So Dr. Agrawal said that if any doctor is not putting that his stress is 9 or 10. So everyone is writing 2, 3, 4, 5, maximum is 5 or 6. So Dr. Agrawal said that 3 is take the 3 as a threshold. If he is above than 3, or he is said that he is in 3 stress score, so he is in stress, otherwise he is not in the stress. So see here, on the second and third day, he said that he is in stress, and our model is also predicting that he is in stress mode, that is in the red zone. So the similar thing has been also here in statistical measure. So we have recorded the values also, that for event 1 means he is in normal state, and that is 1.88 standard deviation away, that we have seen here in the previous graph. That is the first activity. So these are statistical measures, so we can judge that whether he is, how much far he is from the mean, or what is the deviation from that. Then second is that there are a lot of predictions, binary class SBM, one class SBM. So that this model is also predicting that thing, that accuracy of 42.85%, that is out of 14, there are 14 events, 14 days data, and out of 14, 6 has been indicated into the normal class. So from this we can observe that in some cases this doctor is saying that he is normal, but he is showing a stressed state, and sometimes he is saying that he is in stress, and the model is also predicting that he is in stress. So the idea may be that if he is saying that he is in stress, so he may be replaced by some other doctor, or some training may be done for him. So this is another doctor, that is ID5. So here the situation is different. When the doctor says that he is normal, that is following the mean also, but whenever he is saying that he is in stress, he is also following very near to the mean of the original mean. So see here at the event 4, the below figure, the event 4, he is saying that he is in stress state, and the model is also predicting that he is in extremely high stress state. While in the other days he said that he is in stress, but he is following the normal curve. So another thing is that normal versus stress sanctioning. So he has done sanctioning in normal state also, and he has done sanctioning in stressed state also. So in stressed state, the thing is that he is following near the normal state, basically sanctioning procedure in normal state and stressed state. So the similar statistical measure is also done for this also, and here see only 3.57 means abnormality is 3.57. So he is in one of the cases he is in highly stressed state. So another one is basically ID7, that is Dr. ID7. So in this doctor, if you see the below curve, below one is representing the normal versus state. He is saying that he is in normal mode, and he is saying that he is doing normal work, and he is in stressed state. So see here, the graph is very far from for point 1, for the second activity, that is 1 here. The doctor is, the stressed activity, doctor is very far from the mean, and in other cases also, when he is performing normal versus stressed sanctioning, he is far from the baseline. While in the case of intubation, he is following the normal behavior. And the main challenge in this data set is that there are very few points available. So if we say that we can make a general statement that this will be the good one or this will be the that, so that is the issue here. We have only 2 or 3 points, and most of the cases we have only one event that doctor is performing, that is under stress. So likewise, this is Dr. ID 26. He is also very far from the mean, and this is the values here. And the doctor, the average performance that doctor always performing the sanctioning procedure. That is, doctor is stressed such that he is performing sanctioning always. So another one is this normal is, this is 43, Dr. ID 43. So for this, if we see here, the black one is the normal state. Okay, so this is basically his normal is slightly away from the original normal. For event 4, for day 4 and 5, during patient inter red area, he has some variation from the mean, but although he is performing slightly average in this case from the mean. So this is the values. From here we can see also that the values are very small, that is 0.3, 0.30, 0.29, like that from the mean. So this is the report. And now this is the result, that is global result using one class SVM, because one class SVM is the promising method because it detects the distribution of the data. So we have a large amount of normal data set, while the stress data or abnormal data is very few. So when we are comparing normal versus stress, normal versus stress means he is in normal state, and in stress means he is said that he is stressed today and he is performing normal activity, right? So the accuracy is 71.69%. So it shows that approximately 72% of the time doctor said that they are in stress, and that also the following the model that they are not lying inside the distribution of the normal state. So the second one is basically normal cannulation. So normal cannulation versus stress cannulation. So the doctor is performing cannulation under normal mode, that is he said that he is in normal mode, and stress versus cannulation, that he said that he is in stress and performing the cannulation. So the accuracy is about 59% here, so 58% here. So 58% of the time the model says that points lying in this both of the categories, so stress cannulation is outside the normal. So because cannulation is stressful activity, I hope, doctor. So this is stressful activity. So what happens in normal state also the person is performing stress, and in stress state also is performing cannulation. So I think there are large overlap in that situation. So that's why the accuracy is reducing here. So another is basically normal intubation versus stress intubation. In intubation there is a slight increase in the accuracy, that is 73% of the time the person says that he is in stress and performing intubation. So model is also detecting that 73% of the time. While normal sanctioning and stress sanctioning, it is slightly reduced, that is 68%. Time the stress sanctioning is lying outside the normal sanctioning. So this is the result using one class SBM. So this is the summary of that one class SBM. So next is basically summary of outcomes. So basically in all the cases we have performed machine learning approaches. So in machine learning approaches we say that if the accuracy is higher, so sometimes we can say that the model is good, but if we have less number of data points, then there's some situation is something bear type. So but as we have performed here one class SBM is built for abnormality detection, so we can capture all these type of things. So we are able to address almost all the questions, that what is the range of a particular doctor, whether he is needing the assistance or some motivation or some training or not, or we can say that he may be replaced with other if he is highly stressed, like that, using his strength. So analysis may be used for training, healthcare professionals, and observation is that in most of the cases, even doctor has said that he is in stress, but model is showing that he is in normal. He is performing the activity, whether he is in normal state or he is in stress state, that in the same way. That is very near to the mean of the data. So, and in other that is situation is something different, that doctor says that he is not stressed, that is in normal. So this is the thing that we have to pick, that doctor said that he is normal and he is not performing better. That is the model is showing that he is in stress. So another point is that we are also able to predict the unknown events. Suppose we don't know the doctor and we have only recording, and recording came to me. Just I have to say that whether in which category he is lying, and then after that we can make further assessment on that. So this can be also used as a recruiting program type thing. Suppose you are recruiting some professional and you have monitored 2-3 times, and then just checking the trend, what is happening all the time. And second, improvement after training can be checked with trend button. So in the model we have trend button, so we can show the demo. So in that, yes. So
Good demo.
now I can show you the demo here.
So one of the limitations that you had for this work was that initially when I started the project, we thought we'll get the doctors for the whole year round, to collect the data. But here in trauma center, actually most of the residents, senior residents are visiting only 3 months at a time, the rotation. And so that's why for a single doctor, we could not get information on all the events, But that would have really helped in the model. Now, Jamna Prasad will show you the model that was developed, the GUI for this one.
So this is the model. So we have some base data already available. So based on that, we have built the model. So once here is that enter the event list file path. So event list means data recording. So whatever you have recording, you have to put here. That file is in Excel format. That is a standard and a specific format for that file, which recorded all the 4 parameters: heart rate, energy, interbeat interval, and temperature of the body. So we can also say that temperature is not playing very much role in this whole of the model. So, and the second is basically enter the day parameter file. So this file is important because we have to extract some information that from which duration to which duration that doctor is performing a particular activity. Otherwise, what we have to do, we have to scroll whole the sheet, and we have to check randomly whether at any stage of the time any activity is performed or not. So this form says that from this time to this time intubation is performed, or from this time to this time CPR activity is performed. So this is the primary, basically this is the basic. So during building of the model, once we have built the model, then we do not need this form. We can randomize the approach and just check random timestamps and see if there is any activity going on or not. So for example, say here, so we have a test doctor here. So see here, this is a test doctor. We have event sample 1. So this is a recording for a particular specific day. Oh, can see it.
See, what I just put it in layman terms, what is happening is that we have developed a model, IT has developed a model to assess the stress level. So by stress is a very vague term. What we are saying is a doctor who is not competent will obviously have some stress. Now it could be background stress superimposed on it or not, that is different. But whatever the pre-state, if he is not able to handle an emergency situation, obviously the stress, and even nurses. So we assessed both doctors and nurses, and we had everybody wear a watch, and that watch has a sensor, the Sunto watch with a chest strap. So this data was being collected, and via Bluetooth or via USB it was transferred to the PC, and we were simultaneously marking events which were happening. So there was a nurse standing in the ED with a laptop who was marking the events. So any event like a patient comes in, that's an event for us, we mark it. So time stamping on both sides was being done. If a patient undergoes arrest, has some problem, it was marked. So we had defined some 5-6 events, and both sides time stamping was being done. These two Excel sheets were then combined so that we knew what the heart rate or interbeat interval. Interbeat interval, if you read about, it's it's not a new concept, it's been there for a decade or so, which tells the heart rate variation. And it gives a better idea of the stress level. So there are some papers published on that. So we, based on that event trigger, we were seeing what was happening to the doctors or the nurses' heart rate and the interpreted. So then they built a model based on that using whatever data we could accumulate over a couple of years. Our aim was if a new doctor joins or a new nurse joins, we make them wear the watch and the strap and make them work in the emergency for 1 shift, 2 shift, 3 shift, whatever number of shifts, and against the model, see how they perform. So against the model, if we find against the mean, they are within the two standard deviation was my arbitrary way of saying that they are within normal. If it is beyond 2 standard deviation, I said let it be extremely up. So if they are within that, you say okay, fine, you are doing okay. But if they are really out of the 2 standard deviations, we say that there is some problem. And again, an automated way of assessing. Then somebody can go into the picture and say, okay, there is a problem. You are not able to handle the emergency. Is it because of lack of training, lack of experience, or base background, whatever? And then the next step will be intervening, getting them necessary training or experience or mentoring. And what my vision was finally, see, we have a duty rota of doctors and nurses for every shift in the emergency. So if we have every doctors and nurses this stress model available baseline, we can make the duty rota in such a way that you have experienced or low stress people on the duty along with some high stress. So there's always a mix. So you're guaranteeing a consistency of care based on an objective fact. So this is the final vision which we put forward, and this is why they built that model and the GUI interface. So this is still work in progress. We have reached this step, and I think this was our mandate in the project. But the thing beyond is actually to have it practically functioning in a way that we are able to fashion the duty rota based on all doctors and nurses data available. So that is the. So this is just a GUI. It's already a model. Then we just upload the patient's, sorry, not the patient, the doctor's data into it. That's it, and we get a idea. So it is a way you can assess. Any questions on this? So technical aspect, there is no need to know because those who are technical will understand, and those who are not will never understand.
So basically in this, the model is not rich in data. So here also one facility is added. Just suppose you know that this data is good, so you can add the data and update the model. So this is the first button, that is add update model. And if you want to just predict, then just add the data and just predict.
So all these buttons we had them added.
And
so we told them in a lay person what we wanted, and they put it on the technical sense that okay, we said we want the model to be continuously updated because you're putting in new doctors, so it should add to the model rather than just testing the against it. So that's what has been done at the back end. And prediction means if there's no one shift, I just want to know how you perform in that shift. It's like a test. So I'll get to know.
So another one is that suppose we have the data and we are training a particular health professional. So we have check trend here. So in check trend, just enter the doctor ID. So suppose we are setting here 4. This is doctor ID 4. So this will display the trends here like this. So whatever activity they have performed, so they will be cascaded here in a graph, and here you can see that day 1, day 2, day 3.
Who's under high stress, we send him for training, or we supervise him for a few weeks or days, and then again test him, and then we can train him whether it has come down or not. Okay. So that was the purpose of doing it. The biggest, I think, problem we found was in making the doctors and nurses wear the chest strap. So it was a big issue. We had to, and somehow we managed to do this, but that was to make them wear it and keep it wearing throughout the shift. It's a very cumbersome thing. But I think now the new devices are there, sensor, which do everything, so you don't have to wear a chest strap. So I think that obviates this problem, because if you have a watch, then there is no issue. Then we can keep 10 watches. Every person who comes to the India, the healthcare person, make them compulsory wear the watch.
and then automatically data is coming into the system.
How big is that gadget?
That is just a standard watch.
Well, I wear this Fitbit on my chest.
But
and
I
wear
think
it 24/7.
we assessed all the things available in the market. Actually, the interbeat intervals you don't get with any gadget.
Okay.
That you will get only with the Sunto devices, Sunto watches, with a chest strap. Because the chest strap is the
Strap
most
is must.
strap is must. So even now in the latest devices also interbeat interval is not there. So we are still thinking how to get it, because that was the most important parameter in our modeling. So just heart rate itself doesn't make it.
Not even that Apple IQM.
Nothing. I don't know about that. Interbeat interval we are not able to get without a chest strap. So we will review the data. If something comes up, then we will have. Because any new device, we have to again have the whole module come up if we change the parameters. Right now it is interbeat interval.
I have a question. Out of the three models, which one performs consistently well?
Actually, one class SBM is the better one. Yes, better one.
Which one? The first one or the second one?
So second one. So in the first one, because we have binary classes, binary SBM and multi-class SBM, so most of the are overlapping, and the main problem in binary SBM is that the model is biased towards the data. Basically, if you have normal activities, large number of instances, and abnormal activity is very few, so your model will be biased towards the normal one. But in one class SPM, the idea is different. So you have to build model one only on one class, and then predict the that is outlier detection. And another one is statistical measure. Statistical measure is also performing somehow good, reasonable thing that you are seeing in the graph.
So if you can get a device which can get an interbeat interval, then I think we have a very major problem for us will be solved, and we can monitor all the doctors, all the nurses round the clock, get a huge amount of data, and analyze it. Sir.
Yeah, one comment. Do you know that Sunto is a Finnish device?
Right.
Yeah,
Yeah,
it's a Finnish technology, and I'm quite proud to.
If they're anything better than that wearing,
Wouldn't IIT Delhi be doing something?
No, we have been trying.
No, we tried initially, but then evidently is wasting a lot of time in developing technology.
Reinventing a wheel, it will take decades for us. So we actually entered that. In our initial project, we had put a clause that will manufacture or make a prototype device, but it was too much, so we stopped.
Sir, it's not a job of AIIMS, it's a job of more job of an IIT Delhi.
No, we have a department of biomedical engineering here, and the head of that department was a co-investigator with us for this job only.
They tried maybe.
But it could not be done, so we then left.
Was it such a difficult technology?
I don't know. I think the bureaucratic delays caused major problems rather than the technology.
But as this thing, I found it very intriguing. Maybe I read it wrong. You said 72.77% was this thing, and now it's 73%, so it is increasing. I find that very peculiar. I mean, when you talk about, you had mentioned that in one of the slides, that there's a distance between 72.77%, 73% is a major difference or not?
No, sir, what I'll just clarify that whatever they might say statistically, that is different. What we are saying is you take a whole group as a whole. So you have taken 100 doctor sample, taken a mean out of it as a baseline stress level for them. What we are saying is if it crosses 2 standard deviation from this mean, any new person we throw in, we consider that apply. So that is all we are saying. They are testing the various models against each other and saying 72%, 73%. So it has nothing to do with individual data.
I understand. So that means your data is so refined, it's in thousands and millions that you have got so much for small data.
Sir, even for small data you will get this 72.3%. Sir.
It's a very interesting discussion, but we still have an extremely interesting part, which is the panel session, and we are going to discuss all these things which we have discussed today, and we generate new thoughts, new ideas. I invite Professor Kothari to chair this panel session. here. Dr. Indira Ghosh, please. Dr. Shashi Gogia. Shyam, you also should be there. He wants to sit on this side. You want to grill me? Sir, would you be kind to doesn't matter. It's just a discussion. It's nothing. You take us a bit serious.
So before he goes on stage, I would like to
Yes.
just present you the memento as a token of appreciation. Yamuna here.
Sir, please, Dr. Biswas. ये है ना, ये चलेगा ना? On कर देना उसको. Now we almost coming to the end with the panel discussion, and we had really very interesting talk all throughout the day. Can you? मेरा जो word file था ये. So this will be, based on 4 main topics. One is patient's issue for implementation of mHealth. That is first. Second would be role of health informatics in treatment of non-communicable diseases like diabetes. Then role of informatics in trauma management and cancer care. So these are the 3 main, what you call diseases or the patient's condition that we would like to do, discuss on that. Now I don't need to have introduced anybody because everybody has spoken today and participated very actively. So now I'll just ask Dr. Gogia that what do you think the confidentiality of the patient's issue, because we are giving data to the, let's say basically, and let me introduce the topic in the sense that we are going to probably give either a smartphone or a tablet or something to the doctor on this side. Of course, they are sitting in the major hospitals or big hospitals, and that's the meaning of mHealth in the sense that the consultants are on one side, and we are sending the health workers, of course trained health workers, to go into the periphery and reduce the burden to the hospitals. At the same time, we deliver the health to the patient, or the management of diabetes or cancer care or whatever best we can. So by giving these devices to the health workers, and maybe they may be sharing something with that. So what do you think the confidentiality issue in this?
Thank you for asking me this question, which overall, I think in India, confidentiality is not an issue. No patient in India is really bothered about whether his data is going out, which is much more truer in the European and American situation. In India, it is not an issue. For the patient, the primary issue is that he gets the care. And for them, since ages, it is changing now. It is always that they have a lot of faith in the doctor. They used to. I don't know, this is changing. And in that faith, and rarely has,
this is what happened when, and everybody says that India's partition took place because it was not known that Jinnah had tuberculosis. So there probably it will matter, when we are really looking at different. But I don't think that, to my mind, it is a little overrated. That's what I would say.
Anybody here?
Actually, the thing is this, that the confidentiality, privacy, all these issues, as Dr. Gogia has very rightly said, in India, people are not really that much concerned. But my worry is this, that going forward, will the situation remain the same or is it going to change? Because as people become more aware, would they be suddenly, hang on, what are these guys doing with my data? Because this already is coming. See, Aadhaar already is facing a host of problems in the Supreme Court because of privacy and confidentiality issues. People are taking the thumbprint and the retinal scan, and the questions are being raised. What about my fundamental rights? What about my privacy? And the Supreme Court is almost like, Aadhaar is like a no-go area to some extent, and obviously the government is addressing the issue. So my worry is that although it is very correct that today the patient is of normal patient, if you do
most of the
statistical
patients,
analysis, on a random scale, you will find the patient is not really bothered. But what about tomorrow? And anyway, there is a certain category of patients who are going to a certain category of hospitals, like the higher end ones, who are pretty much aware of, and they are not at all interested that their data is floating around. So that this is my.
I think with the court's intervention, probably this is going to change, because if you see the trials, the basic trials, research trials, and court has come into such a thing that you have to keep everything confidential, and again, any trial patient, whatever may be the side effect of whatever, even though it is a placebo or anything, but you have to compensate to the patient. So like that, the legal issues are coming up, and probably we need to go into that direction also.
Better to be proactive rather than reactive.
Yes,
Right,
actually, I would think that it's not necessarily what is going to happen or what trust we have. But as a person, a human being, I would not like all my data to go unwanted place. If it is going, there's a lot of people. So I would like the doctors and the associations to not protect my data, but get some kind of given confidence to me. The data would not be utilized for wrong things, which we do, like surgery. We sign off that anything happens during this course, doctor is not responsible, or even institution is not responsible. So probably the idea is, before we collect the data or flush the data out, get some consent. Many of the people probably would do, and we might better to start with a policy.
I think we should,
place.
And the law of the land, whatever law we have on confidentiality, it should be honored.
Yes.
Now the usability. Do you want to say anything? Yeah, please.
I would ask Professor Biswas.
I would just like to give a rejoinder on this.
Yeah.
So rejoinder basically is that, and I didn't want to dwell too much on that, and Rigor also talked about these things a little in the morning also. Unfortunately, these standardization, confidence, all these things I think have slowed down the growth widely, because they've brought in certain restrictions before it became popular. I would rather let it graduate, and as you said, it is in the future.
Yeah, let it mature. As it comes. Let it mature, and then probably the law on enforcement should be there. Shyam, do you want to add anything?
I might. See, any data which is patient data is in plain American English is called actionable, and any data which is actionable has an economic value. So in that way, you have a large number of patients. For example, even they're taking a particular antibiotic from a particular area, has got a meaning to a particular drug
company or something.
Yeah. So that is on the one hand. Second thing is that when you consider there is an economic value on a patient data, it comes to this issue that it is something like a bank, that you have money in some bank. How secure is that money? How safe is that? How how much information of your transactions are going to people as an actionable, in an actionable. That is one thing. And of course, patient data is, I wouldn't say that it's anyway hindering the growth of I mean, uptake of patient records. I think reasonably good amount of security can and with reasonable amount of what is this called? This
Confidence.
Yes, can
Confidence.
be imparted at the same level as bank data, and that is not a very big issue.
Yeah.
So that can be done.
So I think we should develop a software also like that. At the same time, we should tell the patient upfront that it will not go. And suppose I am doing for my patients or my workers are doing it, so it has to go to the server of the GCRI and probably nowhere else it should go. Yeah.
But I have a question not from medical area, but I don't see what is the difficult thing. As long as you just take out the name and age of the person and keep all the data for the scientific work, it can be given. I think everything can be given except without the name, picture or age of the person.
No, the point is not that you can't.
No, this is going out. My data, I am a patient, my data is going to you and your data is going to somebody else. So that is what confidentiality,
It's not the
what we are.
ethics,
Yeah, research purpose, I don't think no patient would mind. Research purpose, nobody would mind.
I would say his point is well taken. What actually they require is what is called anonymization. That's all. I mean, if you do anonymize, then confidentiality
Yeah,
to some extent is assured.
But no,
That's right.
I have I have something to speak on. See, it's not so easy. It's not so easy. I worked in pharmaceutical industry. I can tell you why it's not so easy. I come from that background, so I can tell you. See, the moment he said that actionable, the data contains some information which one can make monopolize in the long run. That type of data, that's where it comes the actionable. That type of data. This is that type of data. Just think of, you have a diverse genomes people over this country and many complex disease manifested, and the data what you are talking about would have that information.
So I think this area needs to be addressed to.
Yes, in the beginning.
Dr. Deepak, do you want to say anything to this? Huh? Okay. So let's.
One small addition that it's patient information cannot be completely anonymized. A personal information cannot be completely anonymized because a person is tied with several parameters. Say, for example, somebody is living in Delhi, somebody living in South Delhi, somebody is of the age of 56, somebody is working in a university. All these things somehow specifies a person.
Yeah, the profession and
and it's
lifestyle and all that.
Lifestyle, and it's very difficult to completely anonymize somebody.
But actually, that is what you want. You want people in this area. What's happening to them? If you like information on these people, they know that they are living in this area, suffering from this disease.
So that way, for the research purpose, I think no patient would mind. But with the name and all that, so confidentially meaning thereby their personal data should not go away. I had this disease or XYZ had this disease. That's what we meant with confidentially, and that we should ensure as a M-Health provider. Let's say tomorrow we may be. Then I think we should ensure the confidentiality to the patient when we are collecting the data and asking them to participate into this.
And one still another addition is that research nowadays is not only academic research. Research has a connotation with business and with making profit and making money. I mean, they correlate very well these days. So if you are using my data, even anonymized data, and you are using in research, and that culminates into a business and culminates in a profit, somebody intellectual property rights. And then barriers in business verticals, all on my data, but from which I do not get any benefit out of that, and somebody else gets a benefit. There could be an objection in that.
That's right.
So I have a question here.
Yeah.
So as Professor Vishwas said that if once we encrypted the data, suppose you are living in Delhi location and I encrypted this arbitrarily, and we have a good encryption algorithm, and the basic information that provides the name, age, and location and others, so we can encrypt it and just send for research purposes. So I think it will not disclose any type of information about the patient in any case. So encryption, people are using encryption in US hospitals. They release the data. There are already publicly available data. Most of the data set are publicly available for cancers and others. So they just use this technique. They hide all the information using encryption techniques, and they throw the data to public to just research and give new techniques.
But they do take the consent first.
Yeah, no, that is right.
Because
No,
I-
consent has to be there.
Etc. is not the problem. Anything can be encrypted. But first you require
Because in
data
industry
to
also,
take a consent.
because in industry also, there are a lot of things. They are highly confidential. Suppose you are going TCS, Microsoft, Arabian, they have lot of data. You go Twitter, you have Facebook, they have lot of data, but they have privacy concern. They will not give you any information about other persons without any consent.
Who tells you?
Yeah.
Who tells you?
So in Facebook,
Who tells you? The Facebook business model is that.
business model is
Yeah,
only
to use your data.
only small data set
Because you're given.
because
Yeah.
there
Facebook's
was
business model is to use your data in some way or else.
right,
And,
but they
and,
have
and
only
for-
small set of data. So in
for
hospitals
advertisement.
also,
But everybody is participating there.
Facebook is fooling everybody. And
Yeah.
like this free basics.
That's right. Anyway, let's move to the next topic. Otherwise, we'll be just utilizing time in only one thing. Now, second is usability, affordability, illegal access, legal but unethical access, and appropriate treatment. Treatment, we won't come to this, but usability, affordability. I think we had some discussion on this regard, and usability will be restricting to NCD like diabetes, because we want to discuss that, cancer and trauma management. So otherwise it is usable. Usability is in each and every field of the medicine, I would say. So, and affordability. Syam mentioned that the data, the packages are quite costly as compared to probably where he's working, Finland, all that, or other countries, and we get really very small amount of MBs or GBs as compared to other, what you call. At night, sometimes it is slower. After 10 o'clock, it stops. There's so many issues of routine mobile data I'm talking. This we need to go into the field, and that to a place, in a remote place we are talking. So telecommunication companies also should be having a good network setup also. So this is a really intricate thing. We have tablets and we give tablet to 1,000 people, but when the data is not there, it's not going to be. So at the same time, they have to provide services, they have to make affordable. All these things has to be there. Anything on this? Do you want to say?
No, you are talking about usability regarding availability of data connectivity. It's well taken that there is a problem, but I believe that Reliance Jio is going to be a big answer. So, thanks to
Yeah.
So, hopefully that will get corrected.
Yeah, that's
That
right.
is a big issue, definitely. But I would, even in places where it is available, there also usability is the issue, because how good is the user interface? How much actual usability you can derive out? And the most important thing, I think the slowest link, besides connectivity, for getting the data out to different places. Like when you are in JPN Trauma Center or at AIIMS itself, then getting the data out is not the issue. Issue is moving the data inside, and there you have got super fast speed, there it's not bad. But there also, the slowest link in the chain is the actual data. So we need a good user interface, so that you can work faster, and you can get the entire information out in a quick manner, and then also that.
So good and simple software, and probably the language also would come into here, because everybody would not be that much efficient in English, and probably we need to go to that local language wherever we are using, in which state. Here Hindi, in Gujarati language, like that, different.
More so is the even at the doctor's level, there are different demand for different doctors. A patient serving doctor has a different demand. So the software did not be exactly like what we saw. Here it's like expert working. So there should have been, I would have loved to have a GUI where I just type in who are the doctors today are not functioning as well. This kind of GUIs are now affordable, now is available, instead of having the ones that we saw. Those are the ones standard in the book, and academics we do that. But here we require a very different approach. It has to be like very, very like television set you sit and you ask some questions. How we see that answers. They never write any GUI. They just give you the information, some histogram, some other ways. So I think that is another important issue. However, here comes the training.
Yeah, training is
Tie up
most
with the
important.
train. Developing software is no use if it is not
No,
trained.
properly training and proper
It is the
data.
highest difficulty. Not only even developing software is impossible. This
Very
successful experience of Dr. Deepak is because of his team.
Team,
These people who fed data, who suggested the users what they should write, and then they implement it.
I think very few institutes in the country would be having so
Nowhere
many,
I would have,
you know, IT professionals. I would say really. You know, that's.
But I would add to the usability aspect of following exactly the example which is given today. Like it was stated that Polycom 4 lakhs, 10 lakhs, we use Skype. But Skype has got confidentiality issues, and that is the only thing which and it comes back to the same old point. See, usability, anything which is commercially available and used for other things, using that in healthcare will be far cheaper and affordable, because your next topic is affordability. Will be affordable and usable. But suppose I want this software only for myself.
Customization.
Then it becomes very, very expensive. But local customization of available products will be much faster.
But see, looking at the patient and probably seeing the patient remotely from my consulting room or hospital is okay, Skype and all that. But then we need to feed the data also from their center at the remote place. So for that the software will come. So what we need to put the data in, and so that I can give the information back.
Yeah,
Like
that's data entry. That's another
Yeah,
software
yeah,
component.
yeah.
And that should be affordable definitely.
Yeah,
And like he said that they were using open source for that.
But open source softwares are available. Actually, right now, I wouldn't like to use Skype. I have some software I can give you which will work better than Skype. The only thing in open source is that you need few people like he has. He just need the few programmers. They may not be the best on the top, but they need to be in-house things. So everywhere you require the both. But software no longer are built by companies. It's built by free, open source, rather I would say unprofessional, if you may say. And better ones are available on that. So
Right.
Sham should have a comment.
So I think
his
no doubt that
softwares have been done by his students.
I will actually, my students even did my DSc thesis. So it's not, that's a different thing. I would like to get back to Professor Mishra's talks in the morning that we have telemedicine here for last 30 years and it's not that
Picked up.
Yeah, picked up. Why? The first, a few things come in the way, and the first thing comes. Actually, we had Professor Surya Bali from AIIMS today coming, but unfortunately he couldn't come here, and he is actually expert in telemedicine system in AIIMS, and I would have loved him to comment on this. The thing is that the telemedicine systems they are bulky terminals, and you cannot take it as Dr. Boy said, that you need to take this system to the patient, not that the patient comes to the system all the time. You need to reach the end mile, to the doorstep of the patient, and that is one. Second thing is that the system was backed up by this ISRO satellite link, which nobody probably notices that it was at 1200 bits per second link. A link and a video conferencing system per se doesn't make a telemedicine system. You have to check that what is the link, what kind of software associated, what is the software overlaid on that, and what sort of things, whether you can take it. Can you attach any other sensor with the system? Like a smartphone, you can use this
ECG machine or maybe
yes,
sometimes
yes,
X-ray. You can take an X-ray probably.
Yeah,
Just
for example, and
at least
this
screening.
acts as a modem also. That is which connects a sensor, connects a device to another person somewhere else, and a display device or something. So that part, there is a big paradigm change already there from the earlier this big bulky telemedicine systems to handheld telemedicine system,
Yeah,
which is ML.
I agree. I think once upon a time this whole big room, that big computers were there, and now we can held in our hand, rather hold in our hand. So I totally agree with you that telemedicine center is a place-based. We also in our institute, so everybody, or even if it is in the periphery, let's say government has put so many places, but that at taluka level, patients have to go there and then interact with the doctor. Wherein here we are talking of going to the patient, to their house, or maybe a smallest, whatever PHC, PHU, wherein at least some health worker or doctor would be there, and they can communicate there. So it will be in their area, and sometimes in their house when the patient is in a terminal care or whatever they want that way. So that is what we basically want.
Panchayat office.
Yeah, panchayat office something, yeah. Small village, there should not be a problem. Now coming to the fourth topic, I think already we have discussed with confidential legal access, legal but unethical access. I think that is almost covered. So naturally no unnecessary or harmful use should be there except for the research and the patient care purpose should be there. And appropriate treatment. Now what do you think? Do you think mHealth is going to really impact on the treatment part of the patient, or is it going to be limited to diagnostics and giving some help or some advice to the patient? Do you think it is going to make a big dent in a appropriate treatment, Deepak? Yeah.
What I can say, yes, I think it's going to make a major dent. If you look at AIIMS itself, we have so many illiterate patients coming. I'll talk about the 2-3 things which I can think of here.
Yeah.
Illiterate patients, they don't know which doctor to show. Now they have a problem, and the treatment can only be decided by the right doctor. So it's the right department. So if he's got pain abdomen, it could be to any specialty. So
right.
there has to be someone who filters or screens these patients to go to the right department. Because if they go to the wrong department, they're wasting time and that treatment is
right.
So if we can have a clinical decision support system based on the symptoms, right on the mobile phone, which we're trying to do here, then the nurse on the ground, the screening person, can screen and tell them that your department should be here first. And then at the back end, we keep improving our system, seeing how many false referrals or the wrong referrals were there to further improve it. So this is number one step where I think mobile health can be there. The second thing is having algorithms, clinical decision support algorithms in place, so that if you various symptoms which coalesce into syndromes and medication interactions, and there are so many things which will be available at your fingertips, saying that okay, you're prescribing this medication, but this patient has too many other issues, so you need to be careful, change your medication or whatever. So I think these are the things which are the future. Some of this is already available in Western countries, maybe not on the mobile but on the desktop as a built-in part of the EMR. But the best would be it is available at your fingertips. And this is where mobile.
I think the other end, at our end, real experts should be there and they should devote the time. Then only this system is going to be successful, not otherwise.
I would just like to add to this that there is a third component. See, previously telemedicine was described as store and forward or real time. But the third component which has come up and which is now the main thing which is being used in most Western countries, and especially where home health care is involved, is telemonitoring. And
telemonitoring, there are plenty of devices and apps available on the mobile. I know my friend doctor's grandchild, at the age of 3 months or so, she was diagnosed to have cardiomyopathy, and she was given medication in the hospital and all that. Now, just the monitor is there with the child with a mobile phone, which automatically sends a message to the doctor. Every time they whether they need to increase or decrease the dose because she's on like that. So telemonitoring is going to be a big way, and it is going.
I totally agree. Like diabetes, probably we are coming to that. Again, that is a monitoring. Dr. Patel.
You can also use clinical analytics to design treatment protocols for a particular patient. Now, this is where your major data, the data that you collect over a certain patient profile, you anonymize the data and you use it in order to find out what would work best for this patient. Based on the trends and other things, it is possible. Algorithms already exist. And you can also use predictive analytics to find out if I am getting these parameters right now and the patient has this condition, what is the most likely end result of my treatment? And you can find out which treatment protocol.
Or what modification.
Yes. And so you can do it at the beginning and not sort of like as a reactionary process. You say, okay, this didn't work, so let me try this. So you can already do a lot of predictive analytics. Obviously, I'm not 100% accurate. So we would be not going for more than 70 to 80% accuracy. That would be an excellent accuracy. In any case, with evidence-based medicine, 95% accuracy is as good as 100% accuracy. So the 2 sigma, what Dr. Agarwal was saying. So there are very exciting things, but the bottom line is I need data. Without data, I just can't do anything. And the biggest challenge has been to get the data, because not only privacy issues, confidentiality issues, but also because many of the clinicians, and I hate to say myself am a clinician, that we do not like sharing data. Our data, we somehow feel that this is our some sort of money or something. We should have it with ourselves and we should not share it. What is the hesitation? Like most of the corporate hospitals, they wouldn't share the data.
I think in morning, Professor Mishra told that is true also. Sometimes patient would like to come and see the face of the doctor.
Right.
So this is, patient education is also going to be very, very important. That you did not come, we are saving your time, money, everything, and still you are going to get the same advice.
Absolutely. Let's see if you take a telemedicine. Teleconsultation is different from telemedicine. It's a subset of telemedicine. Telemedicine is a whole lot of many other things. But we'll not go there. The thing is this, that if you want to see the patient, you have a smartphone, the other guy has a smartphone, you can see each other whenever you want. If you have a critical patient, you can contact me anytime you feel like. And he can just, maybe he will take only 2 seconds, not 2 seconds, maybe just a minute of your time. But he probably will be much more happier that he has received at least the attention of his doctor, and that will help him a lot. The psychological therapy is very important.
Right.
I would like to happily comment on this because when we started telemedicine and we have done telemedicine projects of our own, some of the people, most of the objections we found were not from the patients but from the doctors. Because the patients, for them, getting, we said telemedicine provides, at those days, now it's better, of course, we used to say telemedicine provides you half a doctor. They say, we just said that where there's no doctor, half a doctor is better than I think. But if the 100% doctor is definitely not better than that. But the thing that I was commenting on, the doctors used to always say that unless I have touched the patient, I don't feel satisfied. I say if you're touching the patient and talking on a mobile, the patient is not satisfied. Just remember that. But if he is looking at his face, then he'll be satisfied.
Right. Okay. Anybody else? Okay.
One nice comment on that. There is a need of touching and interacting directly over the table or on the bed or something. But say, quite often we have a recurrent visits or recurrent contacts needed with the doctor. Say, I have met a doctor, then I wanted to show a blood report, and then I wanted to show a CT scan, and then I suddenly had a problem in the night and I wanted to talk to a doctor, and then in the morning I have a headache and I wanted to talk to a doctor, and all the time I want to go to the doctor's premises,
Yeah.
meet him,
Get an
instead of that,
appointment.
because I mean, one of my doctor friends told me that it takes rather 1 minute, 1.5 minutes to understand what is the problem with the patient.
Right.
It usually doesn't take more time.
Yeah, agreed.
Once you know this patient, once you have touched and hammered and everything, stethoscope, and then you know this patient. But you can keep this contact. It's much more cost effective, time effective, and satisfactory to the patient. That is a point where I would like to like your attention.
No, I agree. Okay, now let's finish with the A and let's go to. How do you go down? It's not going down.
We can close it. Close it now.
Sorry?
Can we close it?
This thing? No, shortly we'll just finish 3.
And suppose we have used the distribution of the data and just create a
Close again.
artificial data and just thrown this data to public for research. Like open source, each open source is developed on some data that is publicly available. All the institutes like Facebook, Twitter,
Frozen हो गया.
everyone is giving some data to get some information and build the software. So
Restart करना
we give
पड़ेगा.
some data that is basically artificial data based on the distribution of the data that is available in the hospital. And now
we-
people are coming and doing research on that
Okay.
and building the models. And we can slightly modify those models and take the best model from the already from the developed models that people have developed in open source.
Okay, I think we are a little running short of time. Now we go to the role of health informatics in treatment of non-communicable disease like diabetes. Now here, screening, diagnosis and monitoring, what you are telling, compliance, treatment and follow-up. So what do you have to say? A patient with diabetes coming from a remote place, of course he will come first time, get diagnosis, and then we have to do everything. Of course, sometimes diagnosis also can be done, but at least after first visit, I would say everything else can be monitored.
ECDs, the thing is this, that you are talking about almost like a lifelong care.
Yeah, this will be
So it becomes really very, shall we say, patient friendly, because the person is already a patient. That if you give him something which is health informatics enabled, that is a host of stuff, then he will be less bothered, because he doesn't have to really run to doctor for every small thing, even for let's say test. He probably would go to the lab, get himself tested, the record is automatically flashed to him as well as to his doctor. The doctor can say you are doing fine, or maybe no, you come in, I need to examine you or sort of modify your treatment. Even the treatment, let's say if it is just a minor modification.
Yeah, that can be done.
It can be done over the entire, it's like a concert, right? And health informatics makes, it's the glue that makes the concert happen.
See, we are giving instruction to the patient on phone, right? So that we are doing today also.
Already you are doing it,
Yeah.
and that you are
Only thing here, they will be able to see the face of each other, which is probably much, will give a closer look to the patient, our personalized look.
Absolutely.
And then if you can modify, I mean, as a doctor I can modify, that is fine.
Face with data.
Yeah,
Face with data.
With data,
and
that's
the
with
thing
data.
is this, that over the telephone there is always a fear that the patient has not noted the medicine name properly.
Yeah,
You have to spell it out.
No, we have to send a text message.
So
That's a message. Or go to the druggist or the
Now, if you have
drug person and ask them to call me.
If you have a health informatics enabled system, you would do that on the EMR. That would automatically
Yeah, automatically
be
it will go.
reflected, and there is no ambiguity.
That's
And
right,
in fact,
that's
the
right.
pharmacist also, because these days we are already in Delhi, you can find, you can actually you can order your pharmacist to send you all the medicines to your home and online and other things. You can even do that. You can integrate it to that, so they would automatically know. They would say, "Would you like to pick it up, or should I send it to
And
your
doctor
home?"
like me will be beneficial because sometimes handwriting problem is there.
Yes. And you can also make that prescription so that it sort of expires after one use, because that's also a problem that many people keep on using
That's
the same
right.
prescription, not knowing what is good or bad for them. There's a host of things.
So there is a Now, Dr. Deepak, this is your area now. We are coming to C. Role of health in trauma management. First aid, that is first contact with the trauma expert, then triaging, treatment center selection, pre-information and treatment center readiness stabilization, and proper referral after stabilization. What do you have to say in this?
I think IT as such, information technology, has a huge role. If you look at technologies which are there, like for example, we were talking, it's fine, we're talking about ultrasound on the scene. I can start from, if you have technologies like ultrasound on the scene, they can transmit images to doctors sitting in the emergency room, and doctors can then guide the paramedics what is to be done at the scene of the accident, and this is happening. So this is the future, and we should be also encompassing what we're doing, so that patients can be triaged appropriately at the accident site. The second triaging and treatment which occurs is at the hospital itself. Here also, based on the vital parameters which are coming into the system, based on a lot of information, like which patient, and this is the problem we deal with every day. You have 3-4 patients coming in together. You have to triage and decide which patient you have to send to the city first, which patient you need to send to the OT first, if there are 2 patients requiring operating room. So all this triaging requires a lot of information, because information is the only basis.
Yeah, naturally.
And this is where information technology can give you clinical decision support, that this, the mortality rate for this will be higher if you delay. So we can triage a lot of things based on information technology. And at the back end, we are creating registries automatically. So for every trauma, be it diabetes, be it alcohol, be it anything, if we use IT right from the time the patient registers to the time the outcome occurs, we'll have very good data registries automatically being populated if we use IT.
Now you talked about sonography, portable sonography. What do you think? PNDT Act and all that. That's again a different ball game. But what I mean to say is a mobile sonography given to the health worker also. I think that again law of the land should be in foreign countries there is no issue. In our country there is a issue.
There is issue, but like in trauma center we're using it regularly, and we have around 6-7 machines of ultrasound with us.
No, institute is okay because we put a board and all that. Yes. But this is we are talking of probably something doing on site or maybe at the accident place.
What the Act says is that PNDT is basically to prevent any misuse of the machine. If you are using it correctly, nobody has any issue.
That's right.
So it is one.
No, portability, unfortunately the portability has gone. Sonography machine were so helpful. I'll tell you, I have a small private also. No, in my private nobody is coming with ultrasound machine. So sometimes I have to send the patient there, even though patient is not in a position to be sent. So now that issue is unfortunately there.
The issue is always there, but we have talked to the experts from PNDT also. We have talked to the government knowledge also. And everybody comes up with the same thing, that if you're using it properly and you're documenting whatever you're doing, then we will be supported.
See, the documenting is that you need 3 different forms for every patient. Even if you forget one form, you are arrested. That is not a thing.
Anyway, of course, not the topic, but because you said ultrasound. But anyway, it's a very good, suggestion that probably all these things, everything that first aid, of course, can be done, has to be done there only. But triaging, treatment center selection, pre-information, everything is possible, and probably the load will decrease and patient will get the proper treatment. That's the most important. And yeah, please, yeah.
I just wanted to say that it is nothing. Anything you put an IT, as in the morning, every speaker spoke and it was very evident. It's recorded. So the first thing is that by IT and the voice even, it's all recorded. So even if you have to fill up 3 forms, all 3 are on record. And it's like duplication of the same thing. So you don't have to write, you have to type it. So everybody would rather prefer that than writing and putting all these. So bureaucracy actually become less when you go to the IT. And hence, bureaucrats do not like IT to be less.
I think
It's
IT
been experienced from
income
so
tax
long.
filing is absolutely now. That's a compulsory.
Well,
So I think it has been
it's
done
a
by
good thing.
bureaucrats.
It's a good thing that
Yeah, it's a
we
good
are
thing.
doing
Yeah, it's a good
that,
thing.
this digitalization
Yeah,
and all
that's
those.
right, yeah.
So the mindset has to be changed. That
That's right.
become more transparency. It is very
Yeah,
transparent.
please, yeah.
This is AIIMS information. I'm just borrowing it that most of the trauma patients come to AIIMS not by ambulances but by autos and
Taxi maybe, sometime taxi.
I mean the majority come by autos. That's what I read recently. And with the help of a tablet empowered with proper information and backed by live experts in a trauma center. Most of the time, auto driver doesn't know how to, even how to. He just simply bundles a guy and puts into the auto, and the idea is to reach at the center. Can it be possible? But a trauma patient needs to be taken care of in the initial stages, in the transport.
So you mean transport is most important,
Yeah,
and probably there is a.
I was putting in my slides that whether would it be possible that this is some kind of dream or something? Would it be possible that every police van can be equipped with such a system so that a policeman can act as a preliminary?
We have already worked on that. We have trained around 2,000 police personnel on basic life support. So Delhi Police has been actively associated with trauma center. They have been training their people because police vehicles are the maximum number of vehicles.
Yeah.
From the official side getting.
Yeah.
After that is the auto rickshaw, as you rightly say.
Yes.
So, and our aim, see, the strategy which we have deployed in Delhi is to scoot and run. So that means you just pick up the patient and you run to the nearest trauma center. So resuscitation and everything is minimized to the maximum possible extent. So our aim of the police vehicles is to not waste time in trying to do anything.
Yeah.
Just make sure basic life support, the patient arrested, do some CPR if possible, and ensure that cervical, neck and all that is taken care of, and they run and take him. So that is what we are training them. Till the time a proper ambulance system comes into it, it is, I think a lot of states in India have that.
108 is of course is there.
Delhi, unfortunately, for some reason, has not been able to do it. But I think it has to happen.
But here in our state and all that, within 5 minutes they are there. 108. It's really a great thing.
CAD services is still there. They are trying to upgrade it, but it is a very costly affair, and they are working on it.
And regarding just the diabetes, of course, going to Anandiben, our chief minister, they have come out with the probably tendering system of glucometer and all that, and they want to give it to each and every place. And whatever may be the gathering, there the testing can be done. Not necessarily it should be a medical camp, because this is basically done by so such thing. NCDs can be really tackled, and there and then in wherever Krushi Meda. So there also you have to check the diabetes. Not necessary only health thing. Now let's go to the last topic, that is role of mHealth in delivering cancer care. Some of things have been discussed, but first and foremost I would say that training and with the training I'll say take education also. So training and education, then advising local doctors in detection and preliminary treatment, second opinion and expert referral, post-surgical care at home and chemotherapy at home under local general medicine practitioner. So there are a lot of things, and palliative care. So let's go to palliative at the end. But training and education, I think that's what I said, that training and education is a really integral part of this mobile system. So many apps are available, how to do breast self-examination, these and that. So and oral care. So those which are preventable diseases, I think we should take maximum user-friendly apps should be made available, and local people and the health workers should be so at least they can take their lecture there and then. Okay, these are the harmful effects and don't do this. Anything else you want to add into that training education? Then advising local doctors and detection preliminary treatment. That is again a big thing, because otherwise patient has to travel so many hundreds of miles and coming just for the diagnosis. So small biopsies wherein not much harm is given to the patient. Of course, not endoscopic we are talking, not deep-rooted biopsies for the tumors, but at least those who are easily accessible, it can be done there. Of course, the specimen has to be transported to a particular or proper place.
No, do you? This is an interesting thing because how much of it, like you have a telemedicine center also, I'm sure.
Yeah, telemedicine center we have.
Do you get the full sample or do you get the slides?
No, for pap smear we get slides because our workers go there. No, biopsies usually don't come. Otherwise, a doctor will take and there is no good facility, so they will send with the patient his own biopsy. That happens sometimes. But for pap smear, we arrange a camp or somebody else will arrange a camp and they will send the whole lot of slides with data. They come to GCRI and then we report in a week's time and send them back.
Because Tata Cancer did have a system of getting the pathology slides from places in Gujarat itself, I heard.
Maybe South Gujarat is possible,
One of the things, I have some personal contact with cancer, so I know a little bit of it. One of the things would be what I see that at the first contact with the doctor, does the general physician, does he understand the general symptoms? There is a deviation from benign situation
to a malignancy.
Yeah, to a malignancy, and quite often the manifestations are very simple, but there's something which strikes the person that this may not be a malignancy, but this is.
There is the role of training. That is the most important. Most important.
And in that situations where he is doubtful, he could probably always consult an expert somewhere remotely that I'm having a doubt on this issue, that this doesn't look me. For example, I'll give you. I had a squarish patch on my toenail, and which could be, say, this what is called subungual melanoma. And I was a bit worried, and I shown to the doctor, and she said that no, it's nothing. But I was not happy, so I published in internet openly, and everybody. Well, this is on a toenail is a black patch, and it could be. So the only way is to take out this nail, and the nail was taken out. The doctor said that look, there's nothing below. Didn't I say? I said yes, fine. But I got the some kind of
good sleep night.
Good sleep, but the problem is that for the next 6 months, my toe was sore. I couldn't put up shoes properly.
Naturally. See, again, as I said, 12th is tomorrow and 19th. We have got about 40 different doctors coming to Gandhinagar, and then we are going as a team, gynecologist, physician, surgeon, and we'll be training them. So this is where their help. So wherever they are coming from different places, about 40 of them. Anand is also coming. I am also going. So we train them, and they should get. But then they should be involved in such activity before they forget, and probably continuous hammering. So training has to be there. So that has to be taken. So governmental, involvement, convincing them that this is a must. I'm sure they are moving in that direction. That that we should do it right at the periphery level rather than everything coming here, and that's what they are aiming. Not many. You treat only complicated cases. Routine cases should be done. And here I would like to say that we have two big Sanjeevani Rath. They are huge, probably 1.5 times the size of luxury bus. We have a mammography machine in there. Sonography was there, but because of this law issue and PNDT Act, we have removed at least sonography because it was portable, and sometimes we can take X-ray there. We can examine the patient, and that goes. We go with the van to the remote place. We take mammography there and then, and those images come here, and our doctors report. So this is a part of M Health. We are doing it, but it should be available at every place. You know, the 2 raths are not sufficient for.
One comment on this. I think that is not needed much great support from anywhere. I think this is one important thing to educate to the mass also. See, the most important thing is the doctors, and then they are training another set of doctors, but still it is a very subset of population. The disease like cancer or diabetes, it is so prevalent and it is coming out in such a big educated.
No, they are education. So that's why I added education of the mass.
In a nutshell, what I want to try, like when there are not many resources, educators, we like to use IT, and that is where probably this type of your workshops and this running through trainings, if you could even make video available. See, this is something which we sometimes ignore. But
Here we can take use of other social organization like Rotary and Lions and going to the remote place and educating. That's what we are doing, lecturing them.
On the healthcare systems, on board, on anywhere. Even the ICMR has, MPS has, everybody has this floating that you can, what else healthcare? Particularly about the breast cancer. This is something which India is just increasing order. If you read Lancet, it's mind-boggling why we are facing so much. Basic reason is not checking it early.
Breast self-examination, we have to teach the woman.
And it's so simple, but nowhere you go.
And mammography.
Nobody goes to. First of all, the women has inhibition, number one, even highly educated women. Second, women and health is most neglected thing in the family. Third is, they themselves do not know how to do that. So empowering the person, at least for the breast cancers, I think is an enormous help. If your education.
There are 3 such cancers. One is oral. We get head and neck cancer, oral cancer in such an advanced stage, and everybody is brushing their teeth, but they don't care to see inside what is happening. So the oral cancer, breast cancer, and cervical cancer. These are the 3 main cancers.
So if you could make some document and find the videos and can we put it online, I'm sure that itself is a greatest help on that.
I have a small comment, and where I'm probably going beyond my boundary where I shouldn't go. One of my friends who is a physicist turned cancer biologist, Professor Michael Redsky, in Boston Children's Hospital. He had a very interesting observation that early detection of breast cancer doesn't help.
Well, that is another thing. Agreed. Probably the period of life from detection to end, it remains the same. That's what it is said. But earlier, I'll tell you, quality of life. If you come at stage 4 and if you come at stage 1, and the way you live probably is different. And you are getting rid of your disease. So these are the 2 things.
Friends who have gone through these, and I've seen the one which is later stage diagnosed and the life of that, and those who have been earlier and how they live. So plenty of my friends have this, and I see the difference of life at least we can make.
One more important thing, that second opinion and expert referral. I think second opinion of patient is taken, and if he wants to send his images to us and to the expert center, that will be really very, very helpful. And the most important is, of course, our rounds in the different wards of the hospital. That is again a dream, but I'm here and I want to take the round of my hospital. So again, my doctor will go with the what he said, actually electronic round, or probably that is also a reality, and it will be a reality after some time. And another thing is palliative care. This is really most important. I see mHealth use will be excellent, because anyway our van with the doctors and the nurses are going to the at least Ahmedabad and peripheral area for the home care in a terminally ill patients. Whereas here our health worker, because anyway they are terminally ill, but to counsel them, to alleviate their sufferings and pain, at least our team, trained team can go and convey to our, Geeta Joshi is, palliative medicine professor. So like her team, if they communicate with them and they advise some treatment, that will be nothing like it. Patient will get a real good medicine advice and they don't have to travel. Right? Anything else from the audience? I think we'll bring this thing to end.